So let us start this event with an invocation to Lord Ganesha. As we all know, he is the Vignaharta. So I just start with a small prayer. Vakratunda Mahakaya. Everybody can sing with me. Vakratunda Mahakaya. Suryakoti Samaprabha. Nirvignam Kurume Deva Sarvakarishu Sarvada. Now I'm sure with all the resonating vibrations, everything will be very auspicious. And I would first like to thank, and of course, it is all because of the efforts of our dynamic president, Foxy Dr. S. Shantakumari, her vision that this particular conference, which is an amalgamation of the East and the West, is taking place today. And also the chairperson of IAEC, Dr. Varsha Baste, she has made such Herculean efforts to see that everything falls in place. Our Secretary General, Dr. Madhuri Patel, Vice President, Dr. Bipin Pandit, who is also the Vice President and Chairperson, VP in charge of IAEC committee. And I would like to also welcome the Chairperson-elect, Dr. Pratibha Singh. She is going to be taking over as the IAEC committee chairperson. Dr. Varsha Lahade, my dear friend from Nashik. There is a strength in numbers, and she's come with a very strong contingent from Nashik. So I do have a home there, so I believe we are all very well represented. Thank you, Varsha. She is the co-coordinator of this event. And we would like to start the sequence of events. I'd hand over to Dr. Varsha Baste to carry on from here.
Hello, everybody. Good evening. Radhe, Radhe. Feels Indian, nahi kya? I'm so happy we could make it. And post-COVID, what has happened, I got elected before COVID. And as a Foxy International Academic Exchange Committee chairperson, we had streamlined so many international programs with the help of Spain government, sponsored IVF hospital trainings and whatnot. Up to December, we were booked. But COVID happened. And in 2019, we could do only our Egyptian tour with the University of Cairo, Dr. Osama Shauki. He was in very much active person who helped us, and with the coordination of Dr. Osama Shauki from Egypt and Egyptian government and Cairo University Dean, we could organize Foxy Cairo International Conference Tour. And it was really hit. We took almost 116 people, members, delegates, with the help of ISAR, IAEG, and Foxy. Then we organized Baku also. So many got enrolled, but because of COVID, we couldn't do it. And I'm really thankful to the travel agency. They could refund up to 95% of the whatever people had paid. We had many programs, but then I went on doing only webinars which were in my hand. And as a social service also during COVID time, abhi kya karne ka, logon ko mental health bhi dekhna tha, physical health bhi. So myself and Dr. Pratibha, she is a national coordinator of International Academic Exchange Committee, we started Rajo. Actually, the Rajogi, the guru, we call him Guru, he's a young boy, Avinash Swankar. He's from Nasik only. And because it takes only 3-4 asanas, so I asked my husband, अरे वो कौन है 3-4 आसन लेता है तो उसको जरा दिखा दो. I liked it so much and I wanted everybody to experience it because my mental attitude, my energy were so high because he took meditation also. And we take meditation very lightly. But it should be in ahar, pratyahar, samadhi, whatever it is, he made it so simplified. So अभी से रिकॉर्ड किया अभी क्या इतने देर नहीं किया ओके delete it. So then we started Raj Yoga and I'm really happy. We did almost 82 sessions and they were all hit. 560 members are there, somehow more than 100. Always join in every week, Saturday. It is free for all. And almost 200 classes have been done because they wanted more of the exposure of our experience of this Raj Yoga. So we started private classes also 3 times a week. And it is also very hit now, people are addictive. We conducted many webinars, many training programs, workshops, but all were online. So I'm really happy. Dr. Shanta Kumari, our president, she said, okay, Varsha, go ahead. If you want to do now, COVID is not there, you can do it. And we will do it with FIGO. So I was so happy. And FIGO president, she couldn't come, but she has sent her a message as address to our this international conference. From Turkey, we could get Dr. Metitil. Thank you, sir, for coming over here. And he's such a renowned person, but only for the sake of one word from Dr. Shanta Kumari, because she's a FIGO treasurer also, and she has so much of hold, I could feel it, global hold. So she requested him and he obliged and he came over here. And the very nice lecture talk we will be going to witness. He's doing so much of work on this topic, overactive bladder. Dr. Ramson Mike, we all know from Ireland. He also obliged, he was going to do virtually, but because of some internet problem, he pre-recorded it and he sent it his talk, which was really hit in Hyderabad conference about this labor first phase of stage of labor. We will be going to see it virtually. And many people like this Mr. Ravi Kaul, our VP in charge, Dr. Bipin Pandit, he helped her. Really, वो मैं उनको बोलती हूँ सर आपके आशीर्वाद से हो गया. He knew Dr. Ravi Kaul, he knew Mr. Ravi Kaul and Smart Travels. They obliged us with everything. Like this hall was also not supposed to get, it was only for 3 hours, but they obliged us, you can use it for whatever time you can. They provided us, this is not done, they provided us audio, visual, everything. And here we are doing our first international FOXI, International Academic Exchange Committee, affiliated with FIGO, with the help of in the presence of our beloved, dashing, dynamic President, Dr. Shanta Kumari, and also our Vice President, FOXI, dear friend, Dr. Kavita Bapat. She also obliged, she came only for the conference and obliged us by her sheer presence. Thank you so much. And I can see many faces, so much dear and near. Just with one call, we were overloaded in 2.5 days. And I had to make it the call. We have stopped more enrollment. Then Dr. MC Patel, sir, senior doctor, is also obliged by his presence. And I can see many doctors, Nasik OBGY, more than 45 doctors came, and our trustee, Dr. Ganorkar madam, she obliged us. Dr. Varsha Lahade, she is the medical legal chairperson of this AMOX committee, and she is the president of Nasik OBGY Society. She, with her sheer determination, with a short notice, she just told him, ajao, and everybody came. And so we could make 192 people to enroll for this conference. Unfortunately, because of few problems in the visa, few people couldn't, they reached Delhi, but they couldn't fly with us. So I'm really sorry for that, but we have already 176 registrations also till yesterday. Today there will be more. It is live on YouTube, Facebook, and also in India. People are watching us, Foxians. Thank you so much. So now I would like to felicitate first our president, Dr. Shanta Kumari Madam. She is such a dynamic person. Dr. Shanta Kumari is a president Foxy. She is a treasurer Figo. She was a chairperson ICOG also, and there are many, many credentials. She is a FRCOG, honored with many honors. And the honors got honored because of her. I would like her to come over, and we would like Dr. Kavita Bapat to felicitate Dr. Shanta Kumari Madam. Just a token. Thank you. Shanta Kumari, felicitate. You cannot predict his age. 10 साल से देखती हूँ वैसे ही है. And he's such a nice fellow, good advisor, and very, very polite and very. मैं बिस्मा चाटी बोलती हूँ उनको. So thank you, sir, for coming all over here. I would like Dr. Kavita Bapat to felicitate Dr. MC Patel, sir. Last but not the least, Dr. Pratibha Singh. My beloved, how can I do without you? She is the president, the chairperson elect of International Academic Exchange Committee. She has honored this post just by winning it, and she has done tremendous work by assisting me. She was our national coordinator. Thank you, Pratibha Singh. Thank you so much. And I know she with her husband, Globetrotter, they will do wonders in bringing up this society, this committee more with their work. I would like Dr. Shanta Kumari Madam to felicitate her. Yes, I would like now Dr. Kavita Bapat also to say a few words. And can I request President Dr. Shanta Kumari Madam? Please, Dr. Kavita Bapat, who is the Vice President of West Zone. I would like her to give the few remarks about this conference to start.
Hi, good afternoon, everyone. I hope everybody is enjoying Entalia. अभी शुरू हुआ है तो भी. So I think it's really congratulations to Varsha Baste. It's an idea to taking 200 people to some other country with backpack or क्या तैयारी or what not. So she needs really a good applause by everyone. Number one. Number two, this type of meetings मुझे लगता है हमको ज्यादा पास लाती है. Everybody is interacted with each and everyone so good that क्या पहना है क्या ड्रेस में, you will be surprised कि international academic committee with so many groups, एक group युवा, एक group what that group is Diva, so what not to wear at Entalia, so they are making this all the preparations for last 6 months probably, and today I am finding it that each and everyone sitting over here enjoying और सब ऐसे बढ़िया ड्रेस पहन के आए. So love you all for being it with us, and it's really the all credit goes not only to the Varsha but our dynamic president. She said कि चलो चलो अब तुम लोग एंटालिया और इस्तांबुल करो और it make it international thing. So congratulations to you, madam, and bringing Figo with it. It's another really a feather in a cap to the our Foxy, and that makes a difference. Thank you so much for voice and everything. Thank you so much for being in, and all the best, Varsha, for any endeavor which we are going to do it. Thank you so much.
Thank you, Vice President Dr. Kavita Bapat, for your kind and nice words and encouraging words. Now I call upon Dr. President Foxy, Dr. Shanta Kumari Madam, to address the gathering. Then we will play the video of President Figo.
My greetings to Foxy and the International Academic Exchange Committee on this important program in Turkey. Mission time, President Foxy and Figo trustee in supporting this information exchange. Your message, exchange knowledge and change the world, is absolutely critical for improving the health and well-being of women around the globe. I know I speak for Foxy, our member society. So when I say that our foundation relies on education, as you're doing here in this meeting, and advocacy, so we're speaking on behalf of women, certainly it relies on strengthening our health systems and building the capacity to provide all of the information and all of the work that we're doing. We also need to be able to interpret research, so we're always relying and sharing the most up-to-date and important information. I was delighted to see that Dr. Kumari has made sure that we are going to have Violence Against Women as a part of this conference. And thank you for all the work that you do on behalf of it. And cervical cancer elimination. Again, making sure that we're able to vaccinate and to prevent cervical cancer is absolutely critical. All of those participating, it is this exchange that is so important. We're looking at our leaders and helping our leaders develop and amplify their voices. Congratulations. I know that that's what you're going to be doing here today. Thank you so much for inviting me to give introductory remarks.
After the address of President Figo, I would like Dr. Shanta Kumari to address the gathering with the pearls of wisdom of knowledge and advise us.
Good afternoon, friends. Namaste, and I bring greetings from Foxy and Figo. It's indeed a pleasure to be here in a place which is away from India, but you feel that you are in India. It's indeed a pleasure to be here for this program, which has been the International Exchange Program of our International Exchange Committee of Foxy, led by Dr. Varsha Baste. Well, she has just given you a gist of what has happened over the past few years after taking over as the chairperson of the International Exchange Committee. Foxy is a very strong body. I know all of you know we are 38,000 strong members with 262 societies all over the country. And we have the Foxy office bearers, which have the administrative wing, which you know, we have the Secretary General Madhuri Patel. The Deputy Secretary General is Dr. Suvarna Kadilkar, Treasurer Parikshit Tank, and Deputy Treasurer is Niranjan Chavan. And the 5 strong Vice Presidents, Dr. Archana Verma, Dr. Basab Mukherjee, Dr. Bipin Pandit, Dr. Fessy Lewis, and Dr. Kavita Bapat, the dynamic Vice President who has come here to be with all of you. And my dear Joint Secretary, Dr. Aruna Suman. We have 27 chairpersons. We have the International Exchange Committee chairperson, Dr. Varsha Baste here. And we have few of them who are elect, Dr. Pratibha, and I think Dr. Surekha Thaide and Mitra Saxena is there, who is a sitting practical committee chairperson. Mitra is here. And elect, I think Surekha Thaide, Charulata Bapai, and Priyankur. And we have got quite a few societies, presidents and past presidents. We have Dr. Achla Batra, who was the president of Delhi AOGD. We have Nasik. We have Dr. Varsha Lahade. And as you have heard, we have Dr. MC Patel, who was the past vice president of Foxy and who is there with us all the way from Gujarat to be with all of you. It all started off, the International Exchange Committee's idea was to connect Foxy with the other organizations across the borders. We have FIGO, we have the AOFOC, we have the SAFOG, and we have so many other organizations who are there globally. When you look at the FIGO, FIGO has 130 countries. And when you look at the organizations, we've got the ACOC, the American Society, then you have got with the Canadian and the part of Mexico, we have the FLASOC, the Latin American countries, the European Board of Societies, then we have got the African Board of Societies and the Asia Oceania, which we are here. It's indeed a pleasure here to have with us Dr. Metis from Turkey. Professor, thank you very much for being with us. Indeed a pleasure to have you with us. Professor C.N. Purandare, who is a very dear friend of Dr. Metis, said, yeah, you can ask him and he will definitely come. He has been one of the strong pillars of the Turkey Society, head of the Department of the Gynecology at the EUTF. He has been representing Turkey from 2004 to 12 on the board of directors of the EPCOC. And he's the second president of the Turkish Society of Gynecology and Obstetrics. Thank you, Professor Ismail Metis. It's indeed a pleasure to have you here. The president who succeeded him was supposed to join. Dr. Metis had invited him, but he had to be out of Turkey for another commitment, so we couldn't have him. The presence of Dr. Metis is very much appreciated, not only by Foxy, but my president, Dr. Jean Connery, has told me very specifically to thank you on behalf of FIGO for being here. The fact that we are doing this program, not only as a Foxy program, but even as a FIGO program, is to bring the global societies together, to make it one. And the presence of the Turkey Society and Foxy here, joining hands for this international exchange program, shows that we are all one global body who is working towards women's health. The presidential theme this year was Foxy for All, Always, and Dhira Stop Violence Against Women, which has been very close to my heart. And Foxy has been working in so many arenas. You've just heard Professor Jean Connery, our FIGO president, who mentioned about vaccination. It is so very important that we obstetricians, gynecologists take care of our women's health. Indeed, all of us know that the maternal mortality has reduced because of the hard work of each and every one of you, my OB-GYNs across the country. But what we find is when we are saving women from dying due to PPH or during delivery, we unfortunately find that women are dying with CA cervix. So I think the responsibility lies with each one of us to make sure that the government and every partner comes together and joins hands with each other to say no to cervical cancer, to have a cervical cancer Mukt Bharat, because India has a high burden of cervical cancer. So we had urged the government of India, Ministry of Health, to recommend HPV vaccination to all girls and women to make India cervical cancer free. And the most important aspect is the screening. The screening for cervical cancer rests on the shoulder of each one of you. Again, I reiterate that every one of you make sure that whoever enters your chamber, let them not leave the chamber without having a perspective examination, without having a screening test, pap smear, the liquid-based cytology, even a simple VIA, which is there in the peripheral, though it may not have a maximum pickup, but still something is being done. And the HPV testing, I'm sure that slowly and strong, steady maintenance of this action will definitely make our country cervical cancer Mukt Bharat, which is so very important. Varsha, the International Exchange Committee was to actually bring together the global forces to come together. And you have told how the committee had planned a lot of programs, but COVID had thought otherwise. But still, we have managed to be here in Antalya for this exchange of knowledge. And I would like to thank Professor Mike Robson from Ireland, who has joined us for the CME and delivered his lecture. Now, because we know the other big challenge is the cesarean section rate. Globally, the C-section rate is so very high. So we need to look at how we can reduce the C-section rates. I think these are the very important aspects which we need to address to bring about a change in the way we practice. Yes, I'm sure that when you come to a beautiful place like Turkey, the priority is to enjoy and relax and chill, but a bit of academics, a bit of CME will add flavor to your holiday also and the academic exchange. So I thank each one of you for joining us today for this wonderful event. And again, congratulations to the whole team, Varsha, and all your team who has worked to make this Congress a success. And Kavita and myself, we have just come down yesterday to be with you all to show that Foxy cares for all the programs. Thank you very much.
Thank you so much. Thank you so much, President Shanta Kumari Madam, for your wonderful, wonderful address. And I would like to take over the proceedings further by our MOCs, dynamic Dr. Priyankur Roy, Dr. Pratibha Singh, who is the elected chairperson of Foxy International Academic Exchange Committee, and Sadhna Sandhya Saharan, who is the past president of Thane OBGY Society. Thank you.
After all the beautiful felicitations, we commence the first session of today's evening by none other than Professor Metitil. Welcome, sir. And to chair this session, we have a senior gynecologist from Nashik, Dr. Ramesh Desle. He has tremendous experience, having put in more than 15 years as class 1 gynecologist in Government Hospital, Nashik. Welcome, sir. We have with us Dr. Nivedita Mondal. She is a gynecologist from Bhilai. She has been the secretary and vice president of the Bhilai OBGY Society. Welcome, madam. We have Dr. Ganpat Sawant, ex-HOD Department of OBGY, DY Patil Hospital, Navi Mumbai. He is also the director of Noble Hospital and Noble Plus Hospital, Mumbai. And he is a committee member of MOGS and IAGE. Welcome, sir. We have with us Dr. Atul Taide. He is professor in HOD, Radio Diagnostics, Sevagram, MGIMS. He has 32 years of teaching experience, and he is also heading the ICMR project on artificial intelligence for imaging in tuberculosis. With this, I welcome our chairpersons, and they will introduce our speaker, the topic, and also conclude the session. Thank you. Dr. Ramesh Desley, may I request you to please introduce our speaker for today?
Hello, good afternoon to all. Respected Dr. Shanta Kumari, President Poxy, the most respected Madam, जुबा खामोश होती है निगाहों से काम चलता है, जुबा खामोश होती है निगाहों से काम चलता है, इसी मोहल्ले का शायद प्रतिभा सिंह नाम होता है. The most vibrant and most dynamic Dr. Mrs. Varsha Bhaste. Respected ladies and gentlemen, I welcome you all in these beautiful premises of Bell County. Dear friends, I want to note that this is the first conference of the Poxy outside of India. Please give the big hand to Poxy. Our Poxy has reached the height of great success. Dear friends, for this session, the speaker is Dr. Ismail Metitil. He is very smart and real human being. He was HOD OBGY EUTF. He represented Turkey, European Board and College of OBGY 2004 and 12. He represented board member of FIGO in urogynecology. His special interest is urinary incontinence and uterine prolapse. Dear friends, he is a really genius in his subjects. I think so. After his lecture, all this audience, your perspective may be changed and you may be treat your patient accordingly. Dear friends, is going to talk on overactive bladder. Bladder is nothing, it acts a pacemaker where it uses the signals to parasympathetic from the sacral and sympathetic from the nerve. Sir, please.
Okay.
May I request, sir, the chairpersons to please take the dais? Sir, Dr. Nivedita? Dr. Taide?
First, I want to thank to all Dr. Shanta Kumari, the Foxy president, and Dr. Varsha Bhaste, chairperson of Foxy committee, and co-moderator Dr. Shureka Tayade, and all of Foxy members. I want to say warm greetings from the Turkish society, and I'm very happy to be here to represent my society in my country in Antalya. And I hope that this meeting will open many doors between connection between Turkish society and Foxy. My topic is overactive bladder syndrome. It is defined by ICAs as urinary urgency, usually accompanied by daytime frequency, and nocturia with or without urgency incontinence. This term may be used if there is no proven local or metabolic pathology. When we look at the epidemiology, more patients have OAB than you realize. Overall, 1 out of 6 adults over 40 years of age in Europe. I think the presentation is not here. Okay. In France, Germany, Italy, Spain, Sweden, the United Kingdom, Japan, and the United States, the prevalence of OAB ranges from 11% to 22%. Okay.
Yeah, no, slideshow. Right.
Okay. The storage and periodic elimination of urine depend on the coordinated activity of two functional units in the lower urinary tract. A reservoir and outlet consisting of the bladder neck, the urethra, and the urethral sphincter. Coordination between these organs is mediated by a complex neural control system located in the brain, spinal cord, and peripheral ganglia. Sympathetic fibers, as you see here, blue ones, originate from thoracal 11 and lumbar 2 segments in the spinal cord and run through the inferior mesenteric plexus and the hypogastric nerve. Parasympathetic preganglionic fibers shown here in green arise from the sacral spinal segments and travel in sacral roots and pelvic nerves to ganglia in the pelvic plexus. As you see, it's a complex coordination system. There are transmitters both in the vesica, in bladder, in urethra, and also the external sphincter urethra. The pathophysiology depends on four roots: uroepithelial factor, myogenic factor, neurogenic factor, and specific conditions like metabolic syndrome, diabetes mellitus, inflammation, and bladder outlet obstruction. Diagnosis of OAB requires exclusion of infection and other pathologic conditions. These are urinary tract infection, pelvic organ prolapse, lower end of the ureter or bladder stone, bladder pain syndrome, interstitial cystite, bladder tumors. In the initial assessment, essential steps are anamnesis, physical examination, neurological and pelvic examination, urinalysis, bladder diary, questioning quality of life, measurement of urine remaining in the bladder after voiding post-voiding residual urine. Urine culture, kidney and bladder ultrasonography, urine flow rate analysis, kidney function tests, cystometry and pressure flow studies are optional. When should invasive urodynamics be performed? If there is inconsistency between patient history and symptoms, failure of empirical treatment, possibility of neurological disease, possibility of obstruction, patient's previous surgery and or voiding symptoms, high-grade prolapse and bladder pain. If there are these symptoms within the patient, then we have to perform, or we should recommend invasive urodynamics. Is there a place for cystoscopy? Yes, if there is hematuria, suspicion of malignancy, possibility of obstruction, and bladder pain, then cystoscopy should be performed. In the treatment algorithm of OAB, there are steps. In the first step, diet, fluid intake, and lifestyle changes with bladder and pelvic floor muscle training take place. Lifestyle changes are losing excessive weight, treat constipation, cut down caffeine like coffee, fizzy drinks, tea, green tea, energy drinks, and hot chocolate, cut down on alcohol, stop smoking, drink plenty of water, and therapy for systemic disease must be performed for like diabetes, hypothyroidism, polypharmacy, bladder diary, and fiber-rich diet. The most important step in both diagnosis and treatment is the bladder diary, because with the help of this diary, we can see the reality, because sometimes the symptoms that the patient tells us does not is not related with the real condition. So with this diary, we can see what happens. The recommended time is at least 3 days. It causes objective assessment of symptoms. Clinical findings inconsistent with the patient's expression may occur. What type of drink and the basis of diet and fluid modification, the basis of bladder training, it's from the bladder diary. And we also can observe the fluid intake, urine volume, if she has polyuria or frequency, and the amount of urine voided at 24 hours and nocturnal polyuria. This bladder diary helps us in many subjects. So it's a strong recommendation that we ask patients with lower urinary tract symptoms to complete a bladder diary as part of the standardized assessment of female loss. And at least 3 days, we have to use a bladder diary. Pelvic floor muscle training is an ancient therapy for urinary incontinence. Kegel improved and has successful results in stress urinary incontinence patients. It is more effective in stress urinary incontinence, but can be recommended also in OAB. It's a first step therapy, but long-term efficacy is not known. The second step, and all we use mostly, is the medical treatment, drug treatment, the antimuscarinics in alphabetical order, you see here, and beta-3 agonists can be used as in the drug therapy and as the second step treatment algorithm. The side effects and efficacy of all antimuscarinics are similar. Dry mouth, constipation, tachycardia, urticaria, accommodation paralysis, effects on the central nervous system. It's very important nowadays. You see the muscarinic receptors distribution and function, and the side effects are related with this distribution. We offer beta-3 agonists as an alternative to anticholinergics to women with OAB who fail conservative treatment. Offer anticholinergic drugs to women with overactive bladder who fail conservative treatment. These are strong recommendations. Consider extended release formulations of anticholinergic drugs whenever possible. If an anticholinergic treatment proves ineffective, consider dose escalation, offering an alternative anticholinergic formulation or the use of mirabegron. Encourage early review of patients of anticholinergic medications. This is 1 month. If you give a drug to an OAB patient, in 1 month, you have to ask the patient if it is effective or not. If it's not, then you will change the step rate or you can pass to another drug. What are the evidences? No anticholinergic drug is clearly superior to another for cure or improvement. Higher doses are more effective to improve symptoms, but also exhibit a high risk of adverse effects. Once daily, formulations are associated with lower rates of adverse events. Transdermal oxybutynin is associated with lower rates of dry mouth. There is no consistent evidence to show superiority of drug therapy over conservative therapy for treatment of OAB. Behavioral treatment may have higher patient satisfaction rates than drug treatment. Adherence to anticholinergic treatment is low, and most patients will stop anticholinergic agents within the first 3 months. As you see here, the oral antidiabetics here, the angiotensin 2 receptor blocker statins, but here you see in the first 3 months, the anticholinergic drug to stop taking anticholinergic drugs is the first in 3 months. In the other chronic diseases, the adverse effects, I think, will last a little bit longer. Mirabegron is the first clinically available beta-3 agonist, has a short time side effect profile equivalent to placebo and similar potentia to anticholinergics, is better than placebo summary of evidence and as efficacy as anticholinergics for improvement of OAB. Adverse event rates with mirabegron are similar to placebo. This is the main advantage of beta-3 agonists to anticholinergic drugs. The only adverse effect is hypertension. Patients inadequately treated with solifenacin 5 mg may benefit more from the addition of mirabegron. A recommendation is offer mirabegron as an alternative to anticholinergic to women with overactive bladder who fail conservative treatment. You see, mirabegron adaptation is better than antimuscarinics in the long-term period. If mono-drug therapy fails, then we recommend combination pharmacotherapy. This is combined antimuscarinic and beta-3 adrenergic agonist or dual antimuscarinic. Combination therapy with an anticholinergic agent plus a beta-3 adrenoceptor agonist, objective and subjective efficacy outcomes and micturition frequency normalization was approximately 2-fold greater with the combination therapy. In those patients with OAB who have a partial but inadequate response to single agent treatment and are unable to access beta-3 adrenergic agonist medications, treatment with trospium plus solifenacin has good results, and short-term cognitive function parameters did not change with the use of higher doses. Medical treatment contraindications to antimuscarinics are narrow-angle glaucoma, urinary retention or detrusor muscle insufficiency, intestinal obstruction or atony, myasthenia gravis, cardiac rhythm disorders, patient non-compliance. Treatment contraindications to beta-3 agonists are uncontrolled hypertension and patient non-compliance. There is a growing data about the cognitive side effects of anticholinergic drugs, and anticholinergic drugs are effective in older patients, but the side effects because of the cognitive effects, we have to be very careful about it. You see the cumulative use of strong anticholinergics and incident dementia here. A patient taking oxybutynin chloride 5 mg a day for more than 3 years would fall in the highest cumulative anticholinergic use category. So oxybutynin in elderly patients, we have to prevent using it a long time. The experts recommend trospium and solifenacin that they think that the cognitive effects are lower. And here, the anticholinergic cognitive burden scale of drugs, the anticholinergic drugs in the severe category. So we have to be careful while using this. Is estrogen has a role in preventing or in treating OAB? Yes, if there is genitourinary syndrome of menopause, means mucosal pellular or erythema, vaginal petechia, atrophia, loss of vaginal rugoia, then vaginal estrogen therapy may improve symptoms associated with genitourinary syndrome of menopause, and OAB can be a component of this syndrome. So if there is genitourinary syndrome of menopause, then you can use estrogen. Third line therapies is recommended if persistent symptoms despite exercise, medical therapy, or combined pharmacologic therapies fail. One of them is botulinum toxin. It prevents muscular contraction by inhibiting acetylcholine release at the neuromuscular junction in bladder. It can be used 100 or 200 units. It is injected into the detrusor, and onset of action approximately 2 weeks, and duration of effect is reported between 3 to 12 months. The disadvantage of this toxin is repeat injections every 9 to 11 months, and patients can receive up to a total of 400 units in a year. 19 studies were identified in the Cochrane review. All studies demonstrated superiority of botulinum toxin to placebo. And intravesical botulinum toxin appeared to be reasonably safe, but however, one study was halted due to a perceived unacceptable rate of urinary retention. So intradetrusor toxin is better than intravesical one. Another way is percutaneous tibial nerve stimulation. It's by a little needle electrode into the lower inner aspect of either leg. The electrode is connected to a stimulator, and the success rates differs from 55% to 80%, but the long time effect is not known. Sacral neuromodulation is more invasive than the PTNS. Theoretically, is thought to act by activation of afferent sacral nerve fibers that inhibit parasympathetic motor neurons. It's an often two-stage procedure, and success rate is if it is more than 50% effective, and it means that it's better than no treatment. Urinary frequency success rate is 56%, and incontinence success rate near 70%. Many studies about the sacral nerve neuromodulation, and the adverse effects is low. The last step is the surgical treatment. If every step fails, then surgical treatment can be recommended. This is reserved for people with severe symptoms who don't respond to other treatments. The goal is to improve the bladder's ability to store urine and reduce pressure in the bladder. However, these procedures won't help relieve the pain. Augmentation and enterocystoplasty, detrusor myectomy are the main two ones. The main principle, enhancements of functional bladder capacity and reduction in spontaneous increments in intravesical pressure. Then, as a conclusion, the bladder diary is the basis of evaluation and first-line conservative treatment in OAB. Oral antimuscarinics and beta-3 agonist therapy are strongly recommended in the second-line treatment of AAV with a high level of evidence. Adherence to anticholinergic treatment is low. Combination therapy of mirabegron with solifenacin has promising results than monotherapy. Cognitive effects of antimuscarinic drugs require additional consideration. Patients aged 70 years, after 70 years with cognitive change or individual with persistent symptoms despite exercise and lifestyle therapies, followed by a trial of at least 2 pharmacologic therapies, warrant referral to a specialist to consider third-line treatment. The selection of third-line therapy, PTNS, SNM, or Botox, should be based on a detailed discussion with the patient regarding safety, efficacy, and time commitment. There is no the most accurate or the best therapy for every patient. There is still a lack of evidence regarding long-term effect and safety of therapies in elderly patients. More RCT and longer follow-up studies are needed. Thank you for your patience.
Thank you very much, sir,
Thank
for a
you.
very comprehensive and elaborate presentation of a complex. Thank you for a comprehensive presentation of a complex topic, a common topic, which is really difficult to manage,
Yes.
stressful, and affects the social life of the ladies. Thanks for the nice presentation.
Thank you.
Hello. Sir, excuse me. As such, there is no treatment for overactive bladder as such. Okay. Lifestyle changing, avoid drinks, spicy food. Sir, but how can we explain anxiety and depression causes overactive bladder?
How can I explain?
Anxiety and depression causes overactive bladder.
I could not understand what you, if you can. If you can,
Question is,
yes.
does it have a root in psychological patients or psychologically
Yes.
disturbed patients?
The some diseases, we don't know the exact mechanism of the overactive bladder. We don't know the exact mechanism of sleep disorders, for example. You give placebo to an sleep disordered patient and say to her that this is this will be good for the sleep. She can sleep with this psychological influence. So the placebo effect in overactive bladder is very high. And related with this, yes, there can be a psychological root. And the recent investigations tells us that we really don't know the basic of this disease. There are 4 pathophysiologic roots, but we don't know, for example, the overactive bladder in diabetes or hypothyroid is different from overactive bladder in a normal person. So they say there's some genetic differences between the patients. There are some genetic differences, and the scientists work on genetic markers, some markers about this disease. So patient-directed therapies will be popular in recent years.
Excellent, sir. So I request our chairpersons, Dr. Ganpat Sawant and Dr. Taide, to give the concluding remarks.
Friends, this was such a practical topic. So many patients suffered from this. But if you see the first slide, what sir said was the basics like rule out UTI, stones, prolapses, and some of the common conditions. So with that, sir, it was a wonderful talk. Everybody enjoyed it. One point I feel is every time we think of female overactive bladder, just think of whether male also have this condition, because they also need to run to the washrooms quite often at one particular age, just to make everybody think about this point out of the box, sir. Thank you very much
I think.
and wonderful talk.
Thank
And
you.
last concluding remark from our President Figo elect and Santa Kumari Madam said, we are global organization doing this. I say this event is a global event for India too, because whole India has come together here, spending time 7 to 8 days. The amount of rapport which develop amongst each other is tremendous, phenomenal. So thank you very much. Dr. Tayri, if you want to say something.
Already sir has told that it is the diagnosis of exclusion, means you have to exclude all the possible causes which causes incontinence or stress incontinence. So the main and second thing is you have to train the patient. Means you have to train the patient. Now pelvic exercise for how many days or after how many days you should refer that patient to the neurosurgeon or for the surgical management, or to refer for the patient for the, and that is my question, sir. So after how many days, means first line of treatment, after how many days or after how many months you will refer that patient to the second line of management or last line of management?
Yes. It's not too long. After first month, we have to call the patient and ask, how is it going? If the symptoms did not improve, then we think that the therapy fails. Then if we give drugs, we can escalate doses, or we can use combination therapies with two antimuscarinics or an antimuscarinic or mirabegron, solifenacin plus mirabegron, and we watch for it for 1 or 2 months, not too long. If fails again, but many improve with these therapies. If this fails, then we have to think about the diagnosis again. If there is an interstitial cystitis or pain, or we need cystoscopy or not, or if it is mixed urinary incontinence. Sometimes in severe stress incontinence, in the last, if in time, it changes to mixed urinary incontinence. So when you operate, also mixed incontinence is cured. So 1 or 3 months in the literature, they recommend to wait after we pass into the other therapies.
Thank you, sir. Excellent. It was really excellent, and this is a burning issue. We are knowing only the tip of the iceberg, how to manage it, and you have really given us a new avenues how to do the sacral and all these neuromuscular stimulation. It was really wonderful.
Thank
And
you.
I would like chairpersons to come over here for a photograph along with Dr. Metitil. Dr. Metitil is a renowned person who has done tremendous work in overactive bladder. He has his training center also. So thank you, sir. We are really pleased to have you here. Dr. Shanta Kumari, madam. And I would like to announce this program is going live on YouTube, Facebook, and yesterday there were 275 registrations from Foxy in India, and more are watching online.
Thank you, sir, for a wonderful talk. And I invite my co-host, Dr. Priyanka Roy, to carry on the proceedings.
Thank you.
You can tell your colleague also in India to watch it live. If it is running on YouTube and Facebook at present. So you can inform your other Foxy friends also.
Thank you, Dr. Sandhya, and thank you, Dr. Mettu, for this wonderful talk, for highlighting and elaborating about the overactive bladder syndrome. Thank you so much. So moving on with the next talk now, we have a talk by none other than Dr. Michael Robson from Ireland, and he'll be talking to us on the management of labor in single cephalic nulliparous woman in spontaneous labor at term. That is the Robson Group 1. So I would first of all like to introduce the chairpersons for this session. We have Dr. Josna Dumbre ma'am with us, who's has special interest in high-risk obstetrics. She's a past president and trustee of the Nasik OBGYN Society and is a senior practitioner practicing in Nasik. Ma'am, can we have you here on the stage, please? With her to chair this session, we have Dr. Birendrajit ma'am, who is another senior practitioner practicing in Chandigarh. She is the HOD at the GMSH Chandigarh, and currently she's also been appointed as the Deputy Director of Health. Welcome, ma'am. And finally with us, we have Dr. Mitra Saxena, ma'am. She is also a senior practitioner from Rewari, currently the chairperson of the Practical Obstetrics Committee of Foxy, and is also a past president of the Rewari OBGYN Society. Can I request Dr. Josna Dumbre, ma'am, to kindly introduce our speaker, Dr. Michael Robson, for his elaborate talk to follow. Can we have the CV of Dr. Michael Robson, please?
Hello. When the words are both true and kind, they can change the world. This holds true for today's speaker. Good evening, everyone. It's my proud privilege to introduce the consultant obstetrician and gynecologist from National Maternity Hospital, Dublin, Ireland. He graduated in 1982. Professor Michael Robson, working in this hospital for more than 10 years, and the hospital delivers 750 women per month, that is more than 9,000 deliveries in a year. Professor Robson's main interest is the management of labor and safe delivery of mother and child. He is the National Clinical Director in the development and implementation of National Electronic Patients Record. Our President, ma'am, Dr. Shanta Kumari, has just mentioned about his work in a speech. Welcome, sir.
Thank you, ma'am, for that introduction. Can I now request Dr. Birendrajit, ma'am, to kindly give us a brief about the topic, management of labor in single cephalic nulliparous woman in spontaneous labor at term.
Yes, we have seen that over the years, the cesarean rate has been increasing, and it is a cause of global concern. In 2015, WHO proposed the use of Robson classification. Over the years, we have seen that the cesarean section rate has been increasing, and it has been a cause of global concern. In 2015, WHO proposed the use of Robson's 10-group classification, and it has been used as a global standard for assessing, monitoring, and comparing cesarean section rates. In the healthcare facilities between them, the system classifies all women into one of the 10 categories that are mutually exclusive and a set totally comprehensive. The categories are based on obstetrical characteristics that are routinely collected. For example, parity, number of fetuses, previous cesarean sections, onset of labor, gestational age, and fetal presentation. So the cases are identified and analyzed. We analyze the groups of women which contribute most and least to overall cesarean section rates.
Thank you so very much, ma'am, for enlightening us about the topic. We were lucky to have Dr. Robson in Hyderabad, India, in the conference which was done by Dr. Shanta Kumari, ma'am. And we will now go ahead with Dr. Robson's talk. Yeah, it will be playing over there, ma'am. I'll just ask them once. If the chairpersons want, I think if you can't see, you can come to the. Yeah.
Priyankur, the volume is not audible. The voice is not audible.
Okay,
Yes.
okay.
Yes.
Good afternoon, everybody. My name is Michael Robson, and I'm going to talk to you about the management of labour in single cephalic melliferous women in spontaneous labour term, Robson Group 1. And to the purists in labour, this is the most important group of women that we look after during labour and delivery. Now, I want to put this into context. The aim of labour management is safe and good care. That's what women, healthcare professionals and governments are interested in. And in my view, at least, this depends on the simplicity and consistency of the care provided. Underpinning everything is continuous and a disciplined structured perinatal audit, with the whole intention being to improve care. The way that I think this is best done is having 4 levels. Start with structure, the 10-group classification system. We include case mix, significant epidemiological factors, in particular age and body mass index. We record all the perinatal events, and we describe this with the processes that we carry out, philosophy of labour. And in particular, in terms of group 1, the diagnosis of labour, eruption membranes, maternal and fetal well-being, diagnosis and treatment dystocia, oxytocin regimen, and analgesia. The whole point about the classification is to embrace the we haven't managed to standardize the type of care which is best, and I'll come back to this later. And rather than concentrating on standardizing processes, standardize the way we carry out audit so we can learn and compare between each other, and also over the years. And no perinatal event or outcome, especially, for example, cesarean section, should be considered in isolation from other events, outcomes, and organizational issues. The principles of labor delivery, we have to make a clear distinction between nulliparous and multiparous, plus or minus the cesarean section scar, spontaneous or reduced labors versus pre-labor cesarean section, and single cephalic labors as opposed to breech and twins, and if you like, transversal lines as well. So what I'm going to be talking about in the rest of this talk is Robson Group 1, spontaneously latent nulliparous women with a single cephalic pregnancy at greater or equal to 37 weeks gestation. Let us start with the antenatal preparation. It isn't always possible. We may not have the resources, but to prepare women for labor is crucial. It's possible even for them to allow to see where they're going to labor and have their deliveries of the labor part. I haven't got time to go into this in detail, but even the classes where we talk about the very basic things that happen during labor, the diagnosis of labor, the use or not of vaginal examinations to assess progress, and also oxytocin and different types of deliveries. They all need to be discussed with women separately, nulliparous women in some groups, multiparous women in others, and not to mix up. But time is well spent on antenatal preparation for labor. We want to try and achieve one-to-one care in labor. Now, I'm not necessarily talking about companions, friends, or relatives, or the partner, whoever the woman chooses. I'm talking about one-to-one care from a professional point of view. In general, this is best provided by the midwife, I feel, and the midwife that's caring in every way for the woman. Now, unfortunately, the number of midwives required to do this is not always there. But also there are more practical reasons why we can't always offer one-to-one care. And that is because labor's been maybe very long. And if they are very long, it's just mathematically impossible to provide that level of care. The diagnosis of labor, when we tell a woman that she's in labor, when we commit to that decision, is a very, very important aspect. And that is one of the key things that we should explain antenatally in preparation. But I would say it's the most important decision in obstetrics, never mind labor, because so much evolves from that decision. I feel the diagnosis of labor is best made by the midwife, the person that's looking after the woman, and is like all other diagnoses based on a history and examination. And the history depends on regular contractions, plus or minus rupture membranes, and confirmed by effacement of the cervix. And I would argue, irrespective of how much the cervix is dilated. But I'll come back to that. So if it's 1 centimeter dilated only, but it's effaced, I would still regard that woman in labor, provided she's got a history of contractions that clinically fits into that picture. And indeed, when you use the partogram, I would also suggest that the partogram is only started when effacement occurs, rather when the cervix is 2 centimeters long, even though you can get 1 or 2 fingers. Typically, the partogram is, and this is the partogram that we use at the National Maternity Hospital of Dublin. So we have a philosophy of care called Active Management Labor. Typically, the partogram is divided into the latent phase, active phase, and deceleration phase. Other people make a big emphasis on these, but we don't feel that the latent phase is actually useful in the diagnosis of labor. And it is the effacement of the cervix that is the key to the diagnosis of labor, as I just described. It is very difficult to know when the latent phase starts, but where we think that that point in the latent phase where the cervix is totally effaced, even though it hasn't got to 2 centimeters, is where labor is diagnosed, where the woman is in labor, and we make a commitment. And in our group ones, 80% of women are diagnosed with labor less than 6 centimeters. Now, some philosophies of care that seems to be totally contrary. Like some people say you have to be 5 centimeters, but I think the key is that the cervix is effaced. This is just a diagrammatically representation of what we mean by a first say cervix to confirm the diagnosis of labor. When the cervix is effaced, you can see in picture 2 there, the cervix is effaced, as opposed to picture 1, even though sometimes in picture 1, you can actually manage to get 1 or 2 fingers through the cervix. Now, there's a lot of talk at the moment in terms of partographs, in terms of diagnosis of labor, whether it's 4, 5, 6 centimeters, and also how we analyze progress once they are in labor. And this does illustrate the point that there are different ways of doing things. Let's embrace different ways of doing things, but let's make sure that we've got audit underpinning those different philosophies of care. As far as I'm concerned personally, the WHO work and the Labour Care Guide and the use of the partogram that they describe there is a little confusing to me, and it's very difficult personally for me to understand. But I think, as I would like to emphasize, if it works, and the result should prove that. But it is important that 10 groups classification is used to analyze that. My own thoughts on the partogram and the use of it, emphasizing the point that evidence-based medicine is in the end personal opinion based on fact, is described here. I think there should be some simplicity and some succinctness, the visual display of relevant information, especially the graph of progress. That's the key point. And the smaller that gets and the bigger everything gets, then I think it gets very confusing to the eye when you actually look at it. It's progress that is important, however or whatever rate you think is normal. I think it's useful to be color-coded, so we use yellow for melliferous women, blue for multiferous women without a scar, and pink for women who have got one previous scar. So this is their section scar I'm talking about now. It's a very easy way of visualizing the different types of women, and they're key to how you would approach not only the diagnosis of labor, but how you would examine and diagnose dystocia. It's initiated on the diagnosis of appointments to labor. The partogram should be committed to before that. You can use other notes for that. And unless the cervix is effaced, the dilatation is recorded as 0 on the partogram. So that will allow for progress in terms of effacement, even though the cervix actually hasn't dilated. It's particularly important when you have inductions who aren't effaced, who started a partogram on them. You will allow for some progress with effacement. I don't think terminology such as alert and access lines, latent active phases I mentioned before, are useful. I think they're confusing and not helpful at all, and divert attention from the important issues. I think that square boxes rather than rectangular boxes should be used in a partogram, so progress can clearly be recognized one by one in terms of the size of the boxes. It's much easier to eyeball progress. If you use rectangular lines, usually on the horizontal axis, then progress seems sometimes a lot slower and maybe may cause more intervention. The graphical representation of labor, what's considered normal progress, or more importantly, what's considered progress that needs to be intervened, has to be agreed in each delivery unit, and there has to be a little bit of flexibility for the person looking after the woman. Fetal monitoring is very important. Again, I don't want to go into detail about that. There are many other people that know much more, but I do think all the different methods should be understood. And sometimes if you are using fetal monitoring, electronic monitoring, sometimes you do need some other way of confirming it. But on the other hand, with good teaching and expertise, the CTG does help. I think though some things are forgotten, and one of the things that we do when a woman is in labor, you must remember that when women come in spontaneous labor, about 50% of women have ruptured their membranes themselves. And we do know the color of the light. This is expected, clear light from left-hand side, going to slightly tinged but normal amount of lichen meconium 1, meconium 2, and then meconium 3, before you can see no lichen, not staying lichen. But in the 50% of women that have come in labor who haven't spontaneously ruptured, we would advise an amniotomy, not to speed the labor up, but to assess the fetal condition at the start of labor. Women may have been low risk technically, but once they get contractions and once they're under the baby's under strain of labor contractions, the life may change. And I think it's a very useful adjunct. It's not the end all, but it's very useful adjunct. And it also may determine at the beginning of labor which fetuses need continuous electronic monitoring and which ones don't. I would admit that it does have beneficial effects. It may shorten the labor, and I think in multiples certainly decreases the need for oxytocin. For our own figures, we've got a very low oxytocin to accelerate labor. In spontaneous multiples, that would be group 3. But the main reason we actually advise amniotomy is to look at the liken. Dystocia. Dystocia is a very important topic and probably the most common problem in obstetrics. And the biggest contributor directly in the particular labor or then indirectly by having had a previous section to the rising cesarean section rate. And we've got to realize that this is the problem. It's not a problem in every group of women that labor, but it is a big problem and a big issue. And the main reason for the difference between section rates in group 1 in different countries in the world. And now that has become quite evident because more and more people are doing the 10 groups. The etiology of dystocia, we all know there's the powers, the passenger, and the pelvis, and it's an amalgam of these in any one particular labor that causes the issue. But as far as spontaneous nullips, it is should always be considered to be poor progress as a result of inefficient uterine action, whether you call it dysfunctional labor, inborn uterine action, whatever, before you consider the passenger, in particular the weight position and any malpresentation, which is a separate issue. They should be isolated. Or indeed the pelvis with pelvic disproportion. It is inefficient uterine action. The contentious issues, I've talked about the diagnosis of labor and assessing subsequent progress. I've talked about artificial rupture of the membranes, and the only other thing which I'll come back to is the incidence, timing, and regimen of oxytocin, which oxytocin regimen is used. And again, remember, we're talking about spontaneously laboring nullips, group 1 and no other group. If you did have efficient uterine action, what I mean is by efficient uterine action is efficient cervical dilatation. We all know that those women will do well. And if they are progressing more than or equal to 1 centimeter per hour, that is very good evidence that they will do well. What we cannot agree on is when you would intervene for progressing less than 1 centimeter an hour, and people have different opinions, and I respect that. And I come back to they have to produce the results. And that's what we can't agree on and how we treat that. So how do we diagnose and how do we treat dystocia? And I'm going to come back to, again, say a few things about our own philosophy. And active management labor, which some of you may have heard of, often misunderstood, misquoted, misused. But it was based on a philosophy that although childbirth has long ceased, present in most parts of the world, at least, a serious physical challenge to healthy women, the emotional impact of labor remains a matter of common concern. And that's true, I think, even today for different reasons. And the basic philosophy of active management labor is the curtailment of duration exposure to distress with avoidance of the physical and emotional trauma which is likely to follow prolonged labor. And that's a very important point to understand. And in fact, if you look at the Cochrane review of active management of labor, although active management labor was an institute to reduce cesarean section rates, it was more to prevent prolonged labor. It is concluded from this paper that it does have small reductions in the cesarean section rate, but it is described here as highly prescriptive and interventional, and that some components of the active managed package are more effective than others. It's a curious description, and in my view, may show a bias, because it does reduce the cesarean section rate. They acknowledge that the cesarean section rate is probably the greater intervention, I would argue, not only in the index pregnancy, but once you've had a cesarean section in future ones. So our philosophy is really based on the fact, and this is a yellow cardiogram, is that we believe once we've diagnosed labor and the cervix is effaced, that a clear pattern of dilatation should emerge. And we believe, our midwives believe, I should say, that this can be determined clinically within the first 3 or 4 hours. We do use, give or take, some flexibility, 1 centimeter an hour as normal progress. And if that isn't, if that progress doesn't take place within the first 2 to 3, 4 hours, then we treat with oxytocin. We believe that 4 hours is too long to wait between examinations to make the diagnosis of inefficient uterine action. And the only way that we can do this to ensure it is do 2 early examinations. Once, however, dystocia has been diagnosed, we do examinations 4, 8, and 5 early because the decision is made and there's no reason to do further examinations. And the total number of vaginal examinations with this kind of philosophy is 3.7 in all spontaneous labor nulliparous, which is a lot less than many with a conservative policy. I would like to emphasize, just as a point of comparison, is multiples, single provided multiples, is very different because the incidence of dystocia is much less, the oxytocin use is much less, 3% in spontaneous multiples versus 50% in spontaneous nullips. So therefore, we would do examinations for family. In fact, we would do everything we can to prevent oxytocin being given in multiples because it isn't required. So this is a classic case. Came in, diagnosis was made, rupture membranes was performed, clear labor. 2 hours later, oxytocin was given and delivered 3 hours later. This wasn't an induction, this was spontaneous labor. That's why it reacted so well. And one of the things we do is we audit our oxytocin very carefully. And from our audit, we know that 2/3 of all oxytocin is given less than 3 seconds of dilatation within 2 hours of diagnosis of labor. So it's basically, if you can spot a problem, dystocia in this case, surely it'd be better to treat it early rather than late. 1/6 of all oxytocin is started as secondary arrest when progress is initially been good, but then oxytocin given, and 1/6 of oxytocin is given in the second stage of labor. And I would like to emphasize our results, which I'll come to again later, shows a cesarean section rate in group 1 of 8%, which is 8 to 10%, which has stayed the same for the last 30 years. And also the oxytocin rate has remained between 45 and 50%. And I don't think if most people actually measured and audited their results, there'll be a lot of difference. You either compromise between giving oxytocin or having a high cesarean section rate. And this is just a summary of what I said. The total oxytocin is 50%. We do have a high dose regimen, if you like. We have increments of 5 millunits per minute every 15 minutes to a maximum of 30 millunits per minute. We have no more than 7 contractions in 15 minutes. If it's 8, it goes down. We're very strict on the oxytocin. And if there's any doubt at all, we would reduce. We never start at the same time as rupture in the membranes. Our epidural rate is 55%. 90% of epidural is given within 4 hours. And as I said, our section rate has been very low. It has increased slightly recently, mainly because of age and BMI, but also because of some women requesting that the management is at the standard as we advise. Now, I want to say a few things about oxytocin labor. There's no doubt that it's potentially dangerous. If you don't know how often you're using it, who you're using it, or how you're using it, or what the overall perinatal outcome is, then that is dangerous. The first question is asked, is it required at all? This is a Cochrane review again, and the conclusion was that you don't need oxytocin, and it makes no difference to either the section rate or any other diagnosis of dystocia. Well, I can't understand that. I can only imagine that the data from which this was drawn, where women were so far on when they were randomized that they were going to do very well anyway. And indeed, they may have even included multips in this thing. Because I think if oxytocin has no effect, well, why are we giving it? It is dangerous. And I don't know whether anybody believes it. It's hard to believe that not giving oxytocin will not increase the cesarean section. Again, as I say, evidence-based medicine is personal opinion based on fact. There have been a number of debates. This is one that I took part with Professor Steer, arguing about the use or non-use of oxytocin. I think personally, and you should maybe read these articles, they're very good and they give the different opinions. I argue that the need for oxytocin is greatest in melliferous women. It's safer to give in terms of uterus, you've got rupture of the uterus. And I made the case that in multips, and certainly multips with a previous scar, that is where you do not need to use oxytocin. It should maybe not. I wouldn't personally use oxytocin in a previous scar. There are low and high dose regimens, as I've explained. Ours is a low dose regimen. But the concentration and the starting dose, even the incremental dose, they're not really the issue. The issue with oxytocin is the effect on the fetus in the uterus. How often you're using oxytocin, how often you need to reduce it, and the consequences on the perinatal outcomes. And that's what you need to be looking at. To actually test regimens without actually test how and what happens when you use them, I think it misses the point. And it's certainly the effect on the uterus. What I'm trying to say also is that a low dose may not be safe and a high dose dangerous. A low dose may actually have an adverse effect on the baby. So when you're using a low dose, don't think, there are no problems or nothing to worry. I've emphasized the 7 contractions, and in multips, for example, we don't give more than, once oxytocin started, no more than 5 contractions. So that's how careful we are. There needs to be a clinical decision-making process surrounding the use of oxytocin. Who's allowed to make that decision? And also, we've got to separate the groups. As I said before, I'd be very hesitant to give it to multips, and very indeed to multips with a previous scar. Breaches and twins, certainly breaches wouldn't give oxytocin to, but some people do. Twins is a more difficult situation. It should be under senior decision, not given in the same way as maybe to a spontaneous knowledge. Okay, and when to start it, first stage, second stage, we've discussed that a little bit. Who starts it? The midwife should be able to start spontaneous nullips, and this is what we're talking about today, but certainly not in twins or the other presentations. Presentations obviously should have oxytocin at all. When you talk about oxytocin in labor, it's not only the oxytocin, but it's the timing of artificial rupture of membranes in spontaneous labor. So if you don't rupture the membranes early on, you rupture them after 4 hours or 8 hours, they clearly are more likely to need oxytocin. And sometimes not enough time, in my view, is left between the rupture of membranes and subsequently starting oxytocin. So the natural processes that start when you rupture the membranes aren't allowed to progress. And if you have a very low dose regimen of oxytocin, you may not ever get to the therapeutic dose. These are all a lot of the reasons why some countries, some units in different parts of the sections. Benefits: it does prevent long labor, it does reduce the section rate, in my view. The risks are mainly fetal hypoxia, but obviously you can have pachycystole and uterine rupture. Uterine rupture doesn't occur in melliferous women. That's a problem more related to certainly exotic, more commonly a problem in multiferous So unless we audit oxytocin in standard fashion, we will overuse it, we'll use it when it's necessary, and we'll use it inappropriately. And maybe also not use it when we should. Taking the whole process further with labour management and spontaneously labouring religious women, it's important to debrief women when appropriate and allow them to choose when they want it. Often just to get explanations about the labour and why certain decisions were made, what happened, and also any information for future labours. As far as structured perinatal audit and caesarean section in particular, which is a very topical issue at the moment, the 10 groups is what we need to use. And you can see here that group 1 is highlighted together with group 2. When you're analyzing group 1, you can never analyze group 1 unless you know all the whole table, but in particular, the inverse of group 1, which is group 2. You need to look at the sizes and how they vary to section. I haven't got time to go through that in detail today, but that's the important point. We split group 1 and 2 into spontaneous, induced labour, and pre-labour section. And it's all those groups that need to be analysed together before you make any interpretation of group 1 on its own. And to classify indications for caesarean section, I think we reject a classification. We haven't got one at the moment. Spontaneous induced labour. Oxytocin necessarily needs to be a part of it. We need to audit other events and outcomes to reflect the management and quality of care. And the classification should be used and be able to use irrespective of the type of management, i.e. these processes that I talked about earlier. And the 3 questions that may help us is the indication for caesarean section fetal, no oxytocin, or dystocia, and has cervical dilatation been more or less than 1 centimeter per hour, then was oxytocin used. And this is a flow diagram which is becoming more used after looking at caesarean sections. And again, fetal, no oxytocin, dystocia, the 2 different dynamics of dystocia, poor progress, less than 1 centimeter an hour, and greater than 1 centimeter per hour. And they're just arbitrary cut-offs, if you like, to divide the dynamics, different dynamics of labour. When there is poor progress or less than 1 centimeter an hour, you may give oxytocin and it just doesn't respond. The baby is fine, the mother is fine, it gets dose. You may be unable to treat it with the oxytocin regimen that you have because of overcontracting, or inability to treat because of fetal intolerance. You keep it at the most appropriate level. And if you end up delivering by caesarean section, you classify it under one of those 3. There are some circumstances in labour you'll allow them to labour, you wouldn't give oxytocin, and that also needs to be classified separately. The efficient uterine action is divided very simply into persistent malposition, efficient uterine action, persistent malposition, and efficient uterine action obstruct. And these are the results that you get when you look at the indications for caesarean section in group 1. And depending on which group is largest or how they spread out, it may push you in a certain direction. And indeed, events and outcomes are all analysed according to different groups. And this is our groups over our group 1 over the years. And I haven't got time to go into it, but you'll be able to see different outcomes and events. Caesarean section fully, caesarean section rate, oxytocin rate, and other events. Informed choice at the end of the day will lead to 3 types of care. Some women have a plan of minimal intervention. Some women will request free labour or elective caesarean section. Others, the vast majority, will prefer short labour, one-to-one care with a high chance of a safe vaginal delivery. And they will be requesting the philosophy of and finally, the biggest advance in 21st century perinatal care to the mother baby is going to be as a result of better routine structured data collection, more sophisticated analysis, improved implementation of appropriate changes, which may be different. Thank you very much.
A very good evening to everybody. I've been asked by Dr. Varsha Baste to summarize this wonderful talk. So I think we are all practicing obstetricians, and the biggest dilemma which we are facing today is to do or not to do. And that is, stemmed on so many factors in our country, how we practice. But the fantastic talk that Dr. Robson has taken us through is a recap of what is the best, and we can always introspect that what are we doing. So let me take you through briefly. The important crux is that we are all concerned about the rising cesarean section, and which is the class where if you don't give a justified delay or a good outcome in the first pregnancy, obviously the next time it will be a increase, because to have a VBAC is much more difficult to give the pregnant lady the best chance in the first pregnancy itself. So defining most important thing is in the topic itself. So term, whenever we consider a patient, we should not be in a hurry to let her deliver before she has completed the term. And now everybody knows it, it's beyond 39 weeks. If the fetus is well oxygenated, an obstetrician need not be distressed. At the most, for our own medical legal safety, we can get a color Doppler after 39 weeks also and allow a uncomplicated nulliparous woman to go beyond 39 or even 40 and actually wait for the next word, and that is spontaneous onset of labor. Spontaneous onset of labor will only happen when we give enough time. So the topic itself teaches us that we should not be afraid to let the patient, a primary, single, cephalic patient, go up to term without, our fear weighing it down. And then once we define labor, that is a very, very important thing, as sir has mentioned. More often than not, it is getting the patient admitted early in labor, where the patient, the relatives, and the doctor all are harassed. In our country, we have a lot of diverse, areas of practice, from a very busy unit to a place where there is only a single laboring woman. So the stress on the unit, which has 20 laboring unit patients, as well as that who is monitoring only a single patient, is almost, equal, because decision-making gets so much more difficult when you are by yourself. So defining onset of labor, and as has mentioned, that effacement is what we all have to see. And of course, with effacement will also come the element of descent. Now, in our country, what is very important is the patient preparation, lots of hop skipping and jumping from one to the other practitioner. So you don't have a continuity with that patient, and the patient doesn't have with you. So it is important for us to make sure that the patient and her family is mentally and obstetrically prepared to face labor at term. Now, another thing is we have to remember that whether the patient is in the latent phase or in the active phase. And now, of course, we all know that before 5 centimeters, if you admit, then obviously it can be a prolonged admission. It's not prolonged labor because she's in, latent phase. So we have to clarify with our patients that this is not prolongation of labor because you're not in active labor. So I think active dialogues between the doctor and the patient is very important. We have to understand that Dublin has been the pioneers, and they are the unit that has always, when we were postgraduates, we were learning partogram from their active management of labor. But in our country, our obstetrics is not midwife-led care. Here, obstetricians who are specialists are doing that care, and it is very difficult for an obstetrician to keep waiting. The masterly inactivity and watchful expectancy, which was the second option, which Dr. Robson had said, that somebody is choosing cesarean, the other person is ready to wait, and the best outcome or the middle path is the active management of labor. So I think it was a fantastic talk in which he has taken us through those debatable points of amniotomy, of use of oxytocin, and the basic tenet is that it has to be your judicious decision making, which is going to make all the difference. And of course, if the intention of an obstetrician is to make a safe vaginal delivery, it is achievable. But of course, there are so many inconsistencies. The use of oxytocin, are we increasing it? Is it being titrated? Are we actually diagnosing dystocia? Have we overcome the inefficiency of uterine action? Is the position all right? So basically, labor is a very dynamic journey, and our decisions can also always keep on changing. So in our country, I think we all have to reassess how we are taking care of our primaries, and especially because increasing cesarean section is causing so many problems. And this first group of patients is the one which needs the best care. So thank you so much. I hope, I mean, this is a lovely talk, and we can all keep on sharing our experiences. Thank you.
Thank you, Mitra ma'am. Would like to thank our chairpersons, Dr. Jyotsna Dhumre, Dr. Birendrajit and Mitra ma'am for chairing this session. And would like to thank Dr. Robson, who couldn't join us physically, but has sent this recording for us, for enlightening us regarding this important topic.
Thank
Can
you,
I now-
Dr. Mike Robson, because when I gave him a time for 20 minutes, he called me up and said, this is a topic which should be discussed for more than 30 minutes at least. So I said, and he specially recorded this talk only for this conference. So we are really thankful to Dr. Mike Robson. Thank you, Dr. Shanta Kumari Madam, also for helping us to have him to talk. This is a very important talk. Both the subjects were very, very important and for good for practical use.
Thank you so much, chairpersons. Now I would like to sign off, and I would like to request my next coordinator, chairperson-elect of the International Academic Exchange Committee, Dr. Pratibha Singh, kindly to take over. Thank you.
Good evening, everyone. And first of all, I would like to thank Varsha Madam for including me in this program. And I also want to thank her for honoring me today. And I'm really indebted to Foxy and all of you for giving me this opportunity to serve as the International Academic Exchange Committee chairperson. So thank you so much. And I have learned a lot from my seniors and all stalwarts of Foxy. So I really want to thank all of you. And I have been actively working with Madam in this committee, and I will continue working in this committee also in near future, and will try to do cross-border international exchange programs as suggested by Shanta Madam. So thank you so much. And I would like to, my regards to all my seniors and all the colleagues who have joined today here for this conference. And now I'm here to conduct this very prestigious oration of this conference. And the speaker is none other than our own Shanta Kumari Madam, President Foxy. And we all have witnessed her successful year of presidentship. Madam's dream project, Dhira Stop Violence Against Women, has made a great impact in our society. Her mission to sensitize 36,000 plus gynecologists, along with boys and girls of 9, 10th, 11th, 12th standard and teachers, has already been successful. And I'm really happy that even I was able to contribute a little bit in this. And today she is here with us. So thank you so much, Madam. And to chair the session, we have equally versatile Foxian. Our first chairperson is Dr. MC Patel, sir, who is very active Foxy member, a very helpful personality. So I welcome sir on the dais. He is past Vice President Foxy, and we all know him. I don't need to introduce him again. And our next chairperson, I'm really very happy to introduce her. She is my dear, my own senior from my own college, Dr. Kavita Bapaddi, a very versatile personality. So I welcome her. She is at present Vice President Foxy, So welcome, madam, to the dais. And our third chairperson is again a very senior gynecologist, Dr. Vijayalakshmi Ganurkar. Madam, kindly come on dais. She is consultant obstetrician and gynecologist in private practice for last 36 years. So with this, I hand over the session to Dr. MC Patel, sir, to kindly introduce our Madam, Dr. Shanta Kumari, for the oration.
Thank you, Dr. Pratibha Singh, for kind words. Appropriate topic, appropriate speaker, and very pleasant moment for me to chair that particular session, because violence against women is very near to heart of our President Foxy, Dr. Shanta Kumari. So she is very right person to discuss this topic. And to introduce her, President Foxy 2021-22, Treasurer FIGO 2021-23, President Telangana Council of OBGYN 2022-24, and she has served so many associations and so many positions. As to narrate some, as a FIGO member for Committee for Human Rights, Refugee and Violence Against Women 2018-21, Chairperson FIGO Foxy ICOG 2018, Secretary ICOG 2015-2017, Vice President Foxy 2013, IAG Managing Committee Member 2012-2018, Secretary Telangana Council of OBGYNS, Foxy Chairperson for MNNRRC Committee 2008-10, National Corresponding Editor for Jogi 2011-2013, and she has many awards and achievements to her credit. And to name few, FRCOG Horatius Koza UK 2018, FRCPI of Royal College of Physicians of Ireland 2017, Fellow International Academy of Human Reproduction IAHR 2021, initiated DHIRA, just I mentioned in prior also, 2016, a socio-medical campaign to eliminate violence against women. 2020, OGHS Lifetime Achievement Award. 2021, MOX, Dr. Ganatra Charitable Medical Center Award. 2020, MOX, N.A. Pandit and Mrs.
Thank you, sir.
Yes. Okay, thank you.
I request before Dr. Shanta Madam starts, I request Jyoti, please invite each and everyone who is standing outside and drinking tea. This is not a simple topic of DHIRA, it's a topic which is concerned to non-medicals also, as well as non-gynecologists also. So I think everyone should come inside. Thank you.
At the outset, my compliments to our Foxy President, Dr. Shanta Kumari, for giving the green signal to my dear friend Varsha for organizing this wonderful conference. And we are all here today.
Thank you.
And just a few remarks regarding this particular initiative. It is the flagship initiative of our President, Dr. Shanta Kumari. She has really poured her heart and soul into it. She believes that violence against women is much more common than what we think. And it is because of this that she has started this initiative of DHIRA to increase the awareness, to sensitize all of us, and to prepare us to stop violence against women. Definite, concrete steps are going to be taken by her in this initiative, because this is something which all of us have to follow. As Dr. Bapat just said, it's a very, very important topic, not only to the gynecologists, but to everyone. I won't stand between you and our speaker and the dais, and the mic is all yours, Dr. Shanta Kumari, to tell us more about DHIRA.
Thank you very much for those kind words. Well, as rightly put, yes, DHIRA means courage. Courage to be able to tell what you want. I think in life, everyone needs to be courageous. Everyone needs to be a DHIRA. DHIRA in Sanskrit means to be courageous. DHIRA in Telugu means to be courageous. So you have the courage to say and tell what you want and to demand what is your right. I think it's so very important that we recognize this very important aspect of being a human being. The power of being Dhira together. Now, why is it that we need to talk about Dhira? Why is it that we need to talk about this? Yeah, I would have given this talk so many times, but every time I give, I feel if I can inspire at least one person to stand up and say, yes, I am going to be there with somebody who needs me, I think then my job is done. Now, what is it that we are talking about today? Now, violence against women is any behavior which is causing physical, sexual, psychological, and reproductive coercion, forcing a woman to live in fear. And why is it that we, as obstetricians gynecologists, are talking about violence against women? It all started way back in 2016 when I became a member of the FIGO working group on No to Violence Against Women. And that day when I became, Diana Galimberti was the chairperson of that committee, and it was a new committee, and we were there to think what it is we can to take care of women's health. And I realized that violence against women is a deep-rooted menace, and it has an implication on women's health. And we need to raise the awareness amongst the various sections of society. And we, the obstetrician gynecologists, are the first point of contact for women who have an issue. And that is the reason we thought we should address this No to Violence Against Women as obstetrician gynecologists. And not only that, I think we need to look into how we can focus the role of trainees, the future torchbearers of women's health, to stay with women's health, to be that supporting action which the women need, not only taking care of their problems as an obstetrician gynecologist, because you are the one person whom the patient looks up to, and you need to have that empathy towards the patient and to focus on the impact of war during pregnancy, to focus on the role of OB-GYN in detecting war. That is so very important as it is when you teach these trainees how to do a vaginal delivery, how to do a C-section, how to do a laparoscopy or any other technique in OB-GYN. So the United Nations has reported that whenever you're talking about forced pregnancy, forced abortion, forced sterilization, or denial of family planning, there are all forms of violence. And Indian data has shown that such forms of reproductive coercion existed in 22 to 50% of cases. And unfortunately, reproductive coercion is a norm rather than an exception. For me personally, it all started way back before in 2013 when I became the FOXI vice president. There was the time where suddenly again we found that the female sex ratio had again dropped, and the government and everyone was focusing on that. So we need to raise the voice to make the society understand the importance of the female child, the awareness in the society. So I actually took the initiative of Save the Girl Child. I'm the future. Invest in me. That's what this little girl was telling us. And that conference we had PV Sindhu, whom I made as the FOXI Girl Child. And she actually went on to become the Olympic champion, and who is the one girl who got back 2 medals to our country. So if the parents of Sindhu had not invested on that girl, have we been lucky to have her to get back those medals? So that is the importance of the girl child, and that's the importance of the parents and everyone concerned to invest in the girl child. So violence against women is perhaps the most shameful human rights violation, and it's perhaps the most pervasive. It knows no boundaries of geography, culture, or wealth. And as long as it continues, we cannot claim to be making real progress towards equality, development, and peace. This is what Kofi Annan has told. It's a beautiful world map. All of you now who are here in Antalya, somewhere in between the Asia, Europe, and Africa. So you all, I know, will be very happy to look at the world map, trying to see which is the next place we are going to go. But wherever you go, you see what is there in common? Violence against women. You go to North America, you go to South America, you go to Europe, Asia, Oceania, anywhere and everywhere, Africa. Don't think that it's there only in our country. It's there in every possible country. Even in the supposed to be the most developed country, like North America, 21%. So everywhere the incidence of violence is there. And unfortunately, in the COVID pandemic, we have seen that it has become a silent pandemic. So stop violence against women. Dheera, we gave the call for action. I started off with first the advocacy and the public awareness. The first time I said, let's do something to focus everyone's attention. Now, how can you catch attention? I said, let's do some cyclothon. Let's do a mass campaign. Let's involve the media. Let's involve the celebrities. So we partnered with the police, the National Commission of Women, the OB-GYNs, the delegates, and everyone, and say no to violence against women. There was a widespread media participation and coverage. That was because we had even a film star who was there from the Telugu film industry. Because unless you have a celebrity, the media doesn't cover even when you pay. So that was a reason why you need to have, and the police, National Commission for Women, everyone. And that's how it started. And year after year, we started focusing in all the conferences we do in 16, 17, 18, 19, and 20. We were doing programs in the our country and in various societies of Foxy. People started doing the program, seeing, yes, it was there in the UFOXy in Lucknow to Indore conference. These were all the conferences. This was much before I became even the president-elect. And there were radio shows, TV talks, and all trying to focus on this violence against women. During this journey of Dheera in the country, in 2017, I was invited to the FLASOC Congress in Cancun, the Latin American Federation, which is a very important component of FIGO. And they're so similar to our Indian, the FLASOC, the South American people. So that was there where I had to actually request Edgar Ivanotis that we have to do this, Dheera. He said, no, it's political. How can we do it? Orange is a political color in their country. We can't, and it's so difficult. Then literally I had to fight with him. Me and Diana was from Argentina. So we could manage to make them agree to a press conference. And there we actually spoke about violence against women. And there I realized many of the women gynecologists said, it's there in all our societies. So to bring it to the forte, to make people aware of this, then during the conferences, we realized that you need to do some sort of gimmicks or something to gain the attention. So we used to do this flash mobs and things like that to sensitize our own OB-GYNs and partner with men to stop violence against women. Even the heading, violence against women, don't you think it's wrong? It should have been violence by the men or whoever. Again, we are actually talking about only the women, unfortunately. And hopefully soon the UN may change the definition. So partnering with men is so very important to stop violence against women. And we did this, and there the FIGO president, CN Purandre, President-elect Carlos were there in Hyderabad with the CEO. And after seeing this, FIGO felt, yes, we have to take this to FIGO. And in Rio Congress, this was a very important Congress where FIGO came forward to do this Dheera. And again, a lot of opposition was there from the Brazil Society. They said, you cannot do it. You can't do it. It's political. But then the FIGO supported me and I said, we are going to do it. The CEO said, FIGO is the global voice of women. The media, the world, everyone is looking at us, how we are going to take care of women's health. How can we not do this? And finally, we said, yeah, you don't allow us on the road, but within the confine of the convention center, we can do it. And there, we actually made sure that there was good global participation, and every society who was there expressed that violence against women is there in their countries. They are treating patients and patients confide in them. It's not only in India that patients will come to us and tell us that they have violence. We'll have to ask our professor friend from Turkey, don't you have this sort of issues in the patients you treat, sir? It is there. Why not? And let me tell you at this junction, Hyderabad, India and Turkey are very closely connected. There are Samdhis. All the princesses, Turkish princesses, were married to our Nawab, Hyderabad Nizam. So all the Ottoman and then the Turkish, who are the ruler, his daughters, Princess Asra, Princess Nilofer, Princess Dureshawar, they were all married to our Hyderabad Nawab sons and their cousins. Nizam. So Nawab Nizam, Hyderabad Nizam. And I have to tell you, these women were very, very progressive. They were all very educated. They were Muslim women, but with a very, very broad outlook. They were all educated in Europe. They were very smart women. And the Nizam was the richest man in the country. So they had the style of living. So they used to do all sort of things, which these princesses never liked, because they realized that women are not given importance. They divorced the Nizam one after one, and they went back to Turkey and other places. But you know what they have done? With the meher money, the money which the husband has to give in the case of divorce, they put it to start the maternity hospitals in Hyderabad. We have the Nilofer Hospital, the Mother and Child Hospital. We have the Dureshawar Mother and Child Hospital, the Princess Asra Hospital. These princesses felt that the women there in Hyderabad, the poor women, they need help. So they said that is the reason why they actually started these hospitals in Hyderabad before they left Hyderabad, 3 of them. And that shows that women understand the problems of women. That is so very important. And I think that is the reason why we as obstetrician gynecologists need to understand the needs of the women. And it was in this Rio Congress, we signed the document with WHO on no to violence against women. And unfortunately, in the COVID pandemic, we have seen that war has become the silent pandemic. And again, you see this photo shoot. This was actually done by one of our colleagues, Mr. Sunil Gulati, who is Narendra Malhotra's brother-in-law. He's a photographer. He said, my contribution. So he did a photo shoot to show. See this, many think that it happens in the lower class people. Is it so? Let's see. So when I took over as the president of Foxy, before taking over, I said, let me do something to make this an issue which is brought into the forefront so that everyone will focus on it and try to reduce the impact. So that's where I decided, no, best thing is to catch them young. I was not very keen on adolescent education or sex education. That's Foxy has been doing from many, many years. But I felt violence against women is something you have to address them, catch them young. So I said, let me start this online school certification course, because that time it was pandemic. So that let us tell the boys and girls about how war is affecting the health and how they should not be silent bystanders. No girl should grow up saying it's okay to accept violence if she has seen her mother or somebody experience it. And no boy should grow up thinking it's okay that I can do any sort of violence. So with that, we started this online school certification course. And to make the children attracted to this, we need to give them a certificate. And that also, if it has a WHO or a UNICEF tag, it will attract them more than a Foxy and Figo. You all are sitting here because you will get a certificate and you're worried when you apply, you have the NMC and all the medical council and such things. So same way, we have to attract the children to also listen to it. The only way is to dangle a chocolate, which is a certificate. But let me tell you, when we started this online school certification course, and the others were the pillars were the courses for the OB-GYN colleagues in the societies, and the other pillar is for the parents and teachers and for the society. So this online school certification is to only talk about how war is an hindrance and how we need to focus on it. Because my ultimate gain of this program and aim of the program is to engage the government, the Ministry of Health and Family Welfare of Women, to make this a mandatory program in the curriculum of the children, so that it's only a 2 hours program. And if this can be made a mandatory course, all children will be have to take part in this program. And I hope by then they grow up, at least when they hear and read about it, then they will understand how they can work towards a more gender neutral society. The second pillar is, of course, the workshop and CME for the gynecologists, where all the aspects of the war and women's health, the sexual aspects, rehabilitation of survivor, and how to create a war-free community. Why is it that we need to do so? To be born as a girl, discriminated from the womb to the tomb. We find right from the pre-birth to sex-selective abortions, to battering of pregnancy and childbirth, to female infanticide, physical, sexual, psychological abuse, to child marriage, to genital mutilation. Even in our country, genital mutilation unfortunately exists in some parts, to abuse and incest, to adult and adolescent. We find dating and courtship violence, cyber violence, violence in the workplace, sexual harassment, trafficking, partner violence, domestic violence, psychological violence. All these are there. Physical, sexual, and psychological. Deprivation and neglect can be considered as a form of psychological abuse. However, these different forms often interact with each other and form a complex pattern of behavior where psychological violence is a combination of physical and or sexual abuse for some settings. Sometimes patients come to you repeatedly, and when you examine, there may not be any problem. They come with white discharge, they come with pain abdomen, they come with vague symptoms. And in spite of telling them that they don't have anything, they keep coming back to you. Did you ever wonder, why is it that this woman is coming back to me? What is behind this presentation? So maybe the violence, domestic violence, something is there. She's trying to look for an avenue to let out. So that is why we need to be empathetic. And this photo shoot was to show, sadly, war is widespread even in the so-called upper class. It has nothing to do with the socioeconomic or the financial status of the woman. It is there right in the rich as much as it is there in the poor. So this certification, we just talked about war, types of war, management of war, bystander role, bridging the gender divide, and peer pressure. So we have, when we look at our achievements, this is an old slide. We have had partnership with the MOU. We made the curriculum. We started the training. We have about 1,240 master trainers. Now it has improved, I think almost 2,000 master trainers we have. We first started off with an online, the first school was an Assam school, the DPS school of Assam. We started it. Many of you are master trainers here. You know more about this program than I know. And this online master training program actually went on very well, and it translated into school programs. And when you see some of the reactions which the children gave, one boy, he asked, yes, thank you very much for doing this program. Okay, not only listening, now you tell me what is it that I can do from my side. And one girl actually said, yes, she said, I'm from Punjab. From this side, this part of the country, this problem is there. And I'm so very happy that you have brought it out for discussion and to help girls like us. Then we started doing a lot of physical programs, and there was a lot of participation from the students, the teachers. In the beginning, some of the teachers and schools were expressing, probably we need to, should we do or not? But after convincing them, they're getting convinced and they're doing this program. And there was a lot of schools in Hyderabad and Vijayawada and all over the country, Ludhiana, then Bhagalpur, Varanasi, then we have seen in the South societies like in Kerala. Saijas was doing this program, and one of the girls, I believe, came out after the program and said, Thank you, Saija sir. Thank you, Foxy. Thank you, Shanta Kumari. She didn't know me. She didn't know Foxy. You know what she told? I am studying in this school. I also have been affected by violence in this school. I did not know what to do. Now, after this program, I have the courage and I know how to handle it. I think that is the best part of this program, where you can make a difference in a girl's life, to be strong, to be courageous. And lot of programs in all over the country we are seeing, and junior colleges, colleges, and participation is so huge. And some of the master trainers are so passionate, they want to do more and more schools. My only wish is that I request all of you all, every one of you have some access to some school, some teacher, some principal. Just tell them and send across. This is a very simple program which can be done. The team is there, and that can make a difference in the future of our country. And what we look at is Hyderabad physical schools. Actually, they did about 31 schools. This was 3 weeks back. By now, another 10 schools were done. More than 5,000 students have been trained. This is a physical program. Online, more than 300 programs have been completed till now. In Agra also, Niharika has done a beautiful program in a lot of schools. There was a lot of media presence also of this program. Because the final goal is to make it a mandatory course. And when you look at the DIRA involvement of the OB-GYNs, we did the DIRA in all the conferences which we did, right from the DIRA walk in the first fun conference, which was the first physical conference last year. And at every event, we are talking about this war, as we are the global voice of women. We celebrated the International Women's Day with DIRA No to War. All the societies did this program in their own societies, involving the police, the local NGOs, and everyone to focus on this aspect. In fact, we had the Commissioner of Health who came to us, and she was sharing some of the experiences. The police officer was sharing some of the experiences. And we have seen that everywhere, everyone knows about this problem. And we need to talk about it to see that we make a difference. In the zonal conferences, right from the Ludhiana conference to the Jabalpur conference to the Ranchi conference, everywhere we are focused on this issue. Allahabad conference, we have an IPS officer, the DG Premchand sir. He said, yes, we are working a lot and we are happy that Foxy is also working. Coming to the FIGO, as the FIGO treasurer, I represented FIGO in the UN General Assembly. The legal obligation with regard to prohibition and elimination of racial discrimination and right to health, and the applicable standard of preventing and mitigating the impact of racial discrimination on health. Racial discrimination, discrimination on caste, these are all forms of violence on women. And when you're talking about health for all women, the universal health, which is a right of every human being, we find that unfortunately, in many of the countries, this is not been given proper attention. Right to equality, free from discrimination, including racial discrimination. Now, if you don't give the woman the right of sexual and reproductive right, then what is it that we are talking about equality? What is it that you're talking about achieving the status of being the best? In fact, Indian women are more empowered than any other country. We had the MTP Act in 1971, which gave the power to a woman to have the right of abortion for her health. And in 2021, we have amended it. And now we look at last year, the Roe and Wade case in US, so very unfortunate that it has been reversed in a country which calls themselves as the global leaders. How can a country call themselves a global leader when their constitution doesn't give the woman an equal right as a man? And they're talking about leadership. I said, excuse me, you have no right to talk about leadership. The UN Third Committee's vice chair was an American, Gay McDougall. In the next panel, when I was talking, I said, madam, they cannot say, you all can't say that you are the world leaders. You need my leadership because my country knows how to take care of women's rights. That is very important. And what is so important is that day after the discussion in the third committee, first time the FIGO was given an opportunity to take part. in the program. And after this discussion, the UN Third Committee wrote back to the Biden government that it really is looking seriously into the reversal of this Roe and Wade case. And this is not the way women sexual and reproductive rights are treated. And this came in the Epoch Times and in the New York Times, and my Jean Connery professor sent it to me. Of course, they didn't mention my name, but it was Figo and I was the one who said it. So I think when all of us start talking about it, we can make a difference to help women to have their access to the sexual and reproductive rights. When you look at the preventable maternal mortality and morbidity, disability, gender discrimination has an effect. And unless we target this discrimination on religion, caste, and ethnic status, even in our country, unfortunately, we find the maternal mortality sometime back in the lower some ethnicity, some racial, some castes, they were more high. So the government and everyone started looking at it and working on it. And slowly, even in those marginalized communities, the mortality started decreasing and the benefits started to be made equal to every woman across our country. So we find that even about 260 million people face caste-based exclusion. I think these are some issues which we need to address as OB-GYNs to see that no woman is discriminated based on their religion, race, caste, or color. And that is so very important as OB-GYNs. So we actually have to show the solidarity with the women and girls globally. The journey of Dheera will never end. That is, the courage should never end. Every woman should have the courage to say no to war. And that is the only way forward. Thank you all for paying your attention. But the only thing which I expect is if you all have not done the program, please go back to your place. Do this program, motivate your at least one school to do this program, and that will make a difference. My team is there, Mr. Ajay Bharadwaj, Sriman, and the whole Hyderabad team is there who can help you to coordinate. Everything is done. UNICEF funding is there, everything is there. You just have to do it. Now I take the opportunity to invite you all to the next Congress of FIGO, which will be in Paris in 9th to 12th October 2023. So FIGO is looking forward to have you all in Paris. Can I have a picture with this?
We should not do the summarize of the oration basically. Shanta madam, मेरे को opportunity मिल गई, so I'm just telling the few things. It's really the flagship project of Shanta Kumari, as madam said. It's very impressive. इस छोटे से project की वजह से I'm just telling you, the even in a FIGO, she has not been. This is a really, it's basically it's a Padma Shri project. I'm telling you, I'm not exaggerating the thing. The India needs this type of project in a future. कि कोई violence against women के ऊपर बात कर सकता है, and really it needs a correction. And we all standing up for ourselves, speaking for ourselves, for the deep-rooted problem. I'm telling you, the female sitting over here, they can understand what I'm saying, what violence, right, from touching to what not. So I think it's a really an implication to the women's health is another important point. Madam, I don't want to do anything, but I'm just putting you the what I have seen as a vice president throughout a year, as a programs throughout what, then the media coverage, the campaign, the flag, the marathons, the Dheera in each and every Yuva Foxy in AICOG also we did. So it's so many things, and I think all the 2566 societies or unko kuch pata ho na ho, I'm sure they know Dheera madam very well, and they are doing it in a right manner. So each and every member of this society knows what Dheera program is, and it's our responsibility to propagate it, to implement it, and to make it a point that this is a really the important project. Thank you so much.
Thank you, Kavita De. And it was a wonderful oration by Madam. And we all know that Dheera is so close to her heart, and it is becoming very close to our heart also. And we are really looking forward that it should spread, at least in all over India, it should spread. And I've seen so many boys and girls, they are talking about that. And so thank you so much, Madam. And I'll request our chairpersons to kindly present this bouquet to our orator, Dr. Shanta Kumari Madam. And thank you so much, ma'am.
Important announcement now, before the panel discussion starts, I would like to tell everybody, we will be distributing the certificates at the hand of Dr. President Shanta Kumari Madam. For the faculty certificates we have, and delegate certificates also we have. And the panel discussion will follow now. But if you are here, then the certificates will be given. But unfortunately, I couldn't carry many. 15 kg lena tha, so 15 I have. So you will just have a photograph with it. The person who is in organization, government service, they want the certificate immediately, they can take it. Otherwise, Dr. Pratibha Singh, you should coordinate with her. Online, all the certificates are available to each and everybody who wants to have them. Thank you.
Thank you. Thank you, madam.
And after the conference, I would like from each member, each team, 2 or 3 members to come forward to experience share their experiences of this Turkey tour. What is their experiences? Dil ki baat, man ki baat, they can tell here and express them, because few groups are completing their tour, few are ongoing. Thank you.
Thank you, Varsha madam. Now we are moving on to our last session, and that is a panel discussion. And to coordinate that, I'll request Dr. Varsha Lahane to kindly come and coordinate the session. Thank you.
Yeah, good evening, everyone. And I thank everyone to be here and present today. After 2 more very important discussions of DIRA as well as cesarean sections, we are heading towards our next panel discussion on cervical cancer, prevention of cervical cancer. I invite the moderators, Dr. Varsha Baste. As we all know, she doesn't need any introduction, but she's a practicing gynecologist from Nasik since last 30 years, director of Baste Maternity and Pushpa Fertility Center. She is CEO and founder of Celgen Anti-Aging Stem Cell Center in Nasik, and she has many publications on her credit. And of course, last but not the least, our very beloved Dr. Varsha Baste from Nasik. And I think I should tell on this platform that she's contesting for vice president, and I request everyone to vote for her, because we are proud Nasikites. We are 40 members here today, and I have the other moderator with me, Dr. Surekha Taide. Is she there in the? Yeah, come. Dr. Surekha Taide, she's a chairperson elect for FOXI Clinical Research Committee. She's a West Zone Coordinator for Practical Obstetric Committee FOXI. She's chairperson for Global Women Health Task Force Network, USA. She's a core faculty for DIRA Project FOXI. She's a founder member and a vice chair for Women Health Together for the Future. She's a national mentor and quality improvement Lakshmanyata project of Government of India. She's a master trainer, emergency obstetric care, critical care obstetric and maternal near miss committee of GOI. She's an expert committee member of national guideline for obstetric guidelines for obstetric and national guidelines for maternal near miss committee. Okay, she has n number of award on her credit and many publications. She's really a dynamic and international lady. So I request Dr. Surekha and Dr. Baste to take over.
Thank you so much, Dr. Varsha Lahade, the president, dynamic president of NOJS Nasik. Hip hip hooray for Varsha Lahade, because she has been the instrumental in collecting, inviting and bringing in many of our doctors from Nasik OBGYN Society. So friends, this is really very important. Our conference is the conference title is Global Health for Women. We had lectures from eminent speakers on recent practical problems like labor first aid. Dr. Mike Robson, very well known for this talk, famous for that, and Naliparas, how to manage in this era of so many cesareans are occurring, and another thing is overactive bladder. So we thought, even our VP also thought, Dr. Bipin Pandit, that cervical cancer prevention will be the best topic for this panel discussion. The moderators, none other than Dr. Surekha Taide, who is a really, what I said, atlas of academics, and myself. So we have esteemed panelists. Let me introduce the panelists. Dr. Achla Batra, who is the past president of Delhi. May I invite you, Dr. Achla Batra. Bharti Abhyankar, very famous for colposcopy. She has made colposcopy world famous. And so Dr. Bharti Abhyankar, you are really much needed for this panel discussion. And Dr. Bharti Mori, past president of Navi Mumbai, very dynamic. She held AMOX so successfully. She's so well known. She dances well. She's attached to many singing groups also. Vaishali Chauhan, I thought our FOXI chairperson should be involved. So we have invited Dr. Vaishali Chauhan, who was the past chairperson of FOXI perinatology. Charulata Bapaye, who is the chairperson elect of breast committee FOXI. Anuradha Kar, who is the dynamic organizing secretary of KISAR and very active obstetrician gynecologist from Bangalore. Then we have Manoj Chelani. He's not present, but he's also president, chairperson elect. Kusumlata Meena. She's the vice president of Jaipur OBGYN Society, and so she's doing so much of work in oncology. So I thought she's the perfect person, apt person for this panel discussion. She should be included. Archana Mishra, she's the past president of Varanasi OBGYN Society. Is she there, Archana Mishra? Yes. And Nishi Gupta, vice president of Ambala OBGYN Society, dynamic person, and she's very eager to be the part of this panel discussion. And Kavita Gandhi, who is the president of Chandrapur, very dynamic, most active OBGYN Society from Vidarbha. So I welcome all you panelists. You are going to bring in excitement and much of the updates that I know for sure. So friends, cervical cancer is the 4th most common cancer in women and 7th overall. Large majority, around 85% of global burden occurs in less developed regions like India and all, where it accounts for almost 12% of all female cancers. Why women are dying? It's an eye-opener. Oh, sorry, Kalpana Kumar, she is a dynamic person, and I invite Dr. Kalpana Kumar. Sorry for not taking your name. It's Dr. Kalpana Kumar. Please join us as panelists. Muhammad Fatullah, President FIGO in World Congress 1997, he said, women are not dying because of a disease they cannot treat. They are dying because societies have yet to make a decision that their lives are worth living. The capacity to prevent cervical cancer requires more than a high-performance screening tests and screening guidelines. So what is the architecture to eliminate cervical cancer? We want to eliminate. Well, how to do it? All countries have to reach less than 4 cases in 1 lakh women. So what are the targets for 2030? 90% of girls fully vaccinated with HPV vaccine by 15 years of age. Catch them young. 70% of women screened with high precision tests by between 35 to 45 years of age, and 95% women identified with cervical cancer disease should receive treatment and care. So the target is 30% reduction in mortality from non-communicable diseases. So what is the primary prevention? 90% of the world girls fully vaccinated with HPV vaccine by 15 years of the age. Simple, because in 2020, it was found, the data tells 71.4 million girls were around 9 to 14 years in India. And of that, 64.3 millions was 90%. So every year we add 1.14 million for the entrant as a cohort for this group. So vaccine hesitancy is there because cost effectiveness, sexual promiscuity, side effects and whatnot. So doubt kills more dreams than failure ever will. So why the vaccine hesitancy is there and what we should do? Tell parents that almost everyone gets HPV and every HPV can cause a variety of cancers in women and men. Remind parents that HPV vaccine is for cancer prevention and provide a strong recommendation for HPV vaccine when they are 11 to 12 years old, and listen carefully and welcome queries, especially about safety. The treatment has shifted through counseling. So let us take the questions. I would like Dr. Surekha Taide to start questionnaire.
Thank you, Varsha Baste ma'am. And at the outset, let me also thank Professor Shanta Kumari ma'am, President Foxy, Dr. Kavita Bapat, Dr. Bipin Pandit sir, for giving this opportunity to me. And the first question to Dr. Kalpana, what is the role of VIA? What do you think? How important is it for cancer prevention?
VIA is visual inspection of cervix after application of acetic acid. This is a very important screening test, and it is as important because it is very easy to do it, and you can do it while you are examining your patient for the first time by per speculum examination, and it gives a result immediately, but you have to understand the exact positive or negative test. When will you call it negative or when will you call it as positive? You have to use, it is very easy to keep the things ready in your OPD setup, and you can put the acetic acid over the cervix. You have to wait for 10 seconds and you see the changes in the cervix, color changes in the cervix. It happens because neoplastic cells have more chromatin material, and this acetic acid neutralizes this, coagulates this protein and make it more white. So this is the theory behind this test. And it is important because this test is to be taken as screening, as well as this test can be used as triage test. That means you can combine this test after doing other tests like HPV or cytology. So WHO has recommended this test as screening and test also, that you have screened the patient, and if it is positive, you can treat this woman then and there. Of course, you have to see whether the patient is prerequisites for all the treatment for ablation or anything which you have decided are fulfilling or not. And you can add this test as triage test also. Only problem is that you will not get the sample to see, to confirm the histopathology
Yeah.
of the
Hello.
issue.
Yeah. Thank you. Thank you. I think that was very elaborate. And let's remember that the VIA is the screening text. Actually, we can teach it to our primary healthcare workers also. And definitely it has its own role. As we would be going forward in the panel, we would come to know more about how to triage with the help of VI also. So this is what yeah, Dr. Kalpana was talking about, the screening recommendation, screen and treat for the general population, either that or screen, triage and treat. So HPV DNA would be the primary screening test starting at the age of 30, and you will have a screening interval for 5 to 10 years. For women living with HIV, screen, triage and treat is the only option which WHO has recommended. HPV DNA as the primary screening test. Start early at the age of 25, and the interval is reduced to 3 to 5 years. Okay, so this is what Dr. Kalpana said, screen and treat versus screen, triage and treat. And these are the recommendation when providing HPV DNA testing. WHO suggests either provider or self-collected samples can be used. And of course, this is how the cost can be brought down. You know, if the cost of HPV alone and HPV with triage, they are found to be similar. More treatments with HPV, so we have to triage them. Fewer treatments with triage, greater cost of additional testing with triage. So both are, you know, on a similar platform. If you compare them, choice depends on the contest, the capacity of the health system, the access to the services, HIV prevalence rate, the acceptability of treating women without the lesion. So if the woman doesn't have the lesion, but VIA is positive, then you have to decide the pros and cons and decide whether you want to see and treat or see, triage and treat.
Excellent, Dr. Surekha. Now this next question to Nishi Gupta. What are the ablative procedures available? Can you elaborate them?
The basic principle of ablative procedures is to destroy the entire transformation zone up to the depth of 7 mm. It is based on the observation that SIN may exist up to 4 mm inside the gland crypts, and hence 7 mm is a suitable safety margin. The prerequisite for ablative methods is that the entire portion of the lesion and the transformation zone should be fully visible, and there should be no or minimum endocervical extension of the lesion should be there. A colposcopic biopsy must be taken from the most suspicious area. And there should not be any suspicion of invasive cancer or the glandular disease. And there are various types of ablative methods. First in use is the cryotherapy. Cryotherapy is the application of extreme cold to destroy the precancerous tissue. And cryotherapy leads to cryonecrosis through several processes. First is there is intra and extracellular crystallization leading to dehydration, thermal shock, vascular stasis, and protein denaturation. There can be rapid freeze followed by a slow thaw is the most effective procedure. Double freeze thaw cycle is most effective than a single cycle. And method of choice is low resource settings. So the advantage are simple, effective, inexpensive, relatively easy to learn procedure. But the disadvantage is tissue is not available for physiological examinations. Others are laser vaporization and radical diathermy, etc.
Yeah, so what is important is the timing is also because of previously we used to give only cervical erosion is only 8 minutes ago, but the timing is the guidelines say that it should be more than 3 minutes. Minimum 3 minutes is the gold standard. So what is laser vaporization? Yeah. Anybody can take it.
So of course, we are talking of the ND-YAG laser, which can be used. Anybody of you want to
There are
talk
very
about
few
it?
centers, but still laser vaporization is one of the procedures.
Hello, instead of laser vaporization, which is used very rarely, I would like to narrate about next ablative procedure, and that is thermocoagulation, which is very commonly used nowadays. And over cryotherapy, it is a much preferred procedure. It is easy to perform. It has a lot of advantages over the cryotherapy because we know the various disadvantages like watery discharge and itching and everything with cryotherapy, which is not the case with thermocoagulation.
Yeah.
So thermocoagulation is the next choice ablative procedure.
Yeah, the only thing is cryopreservation, cryocautery is very, very good. I think only the disadvantage is copious discharge. So we have to counsel the patient. It will last for 6 weeks to 2 months. So पहले से बता देने का है कि इतना होगा ही. So she is mentally prepared. Otherwise they come back again and again, madam इतना जा रहा है, इतना जा रहा है, and then they feel panicky. So two mics.
You
there.
have to have the equipment. It's an expensive thing
Yeah,
to have a laser. You can't have, everyone cannot.
Yes, yes, absolutely.
So
There are very
common-
few centers in India.
So-
We are having
so-
it, but as a to complete the list, yes, Dr.
So
Bharti.
that is what with practice in India, where we can't afford the MDAC laser treatment. I think cryotherapy, which is available at all Gynaec centers in
I'm
India,
having it from
and
25 lakhs and it is excellent.
and
the
it gives
new-
excellent
newer-
results
newer
also.
machines are coming up in therapy where we can insert in cervix, also internally cervical canal. But my cryopreservation, my cryotherapy unit is since 25 years, it is working so well and giving so good results.
and it gives good results also.
So next question to Dr. Kavita. What do you think are the advantages of excisional procedures over the ablative ones? Dr. Kavita?
Kavita Gandhi.
Kavita Gandhi, ma'am, is not there.
Anybody
Anybody
can
else
take-
can
yeah,
take
she's
the-
there, she's there.
She's there, yeah. Please, ma'am.
Whenever we are not able to, whenever the patient's lesion is not fulfilling the all prerequisites of ablative procedure, that is, if your lesion is big one and your probe is not covering the entire lesion or your transformation zone is not visible, then you can go for, or the lesion is having multiple quadrants, then you can go for excisional procedure. So LEAP is supposed to be the best to doing this excisional procedure, that is large loop excision of transformation zone, you have to do it. And this is also very common. An advantage of LEAP over the ablative procedure is that you will definitely get a tissue for biopsy for confirmation of your disease. So this is the advantage over the LEAP procedure. So excisional is many more methods are available for excisional procedure. So I am talking about LEAP only, or should I talk some more?
That's it.
Yeah, LEAP is there.
So Dr.
LEAPS
Bharti
is-
More.
yeah.
Do you want to
LEAP
say?
and LETS is also there. Also large loop excision of the transformation
Yeah.
zone is there.
Only one important thing is that the loop should be greater than the lesion. So you can, otherwise you can take multiple sections. So what is cold knife conization? Bharti More, are you doing it? We used to previously practice with this. This was the good method for us as a senior obstetrician gynecologist. What is your opinion?
Yeah,
about-
this is one step beyond the coagulation, the diathermy that you do. In this, most important thing is the condition. If there's a disparity between the colposcopy and the cytology, basically good old days we used to do only pap smears. And now the basic test that they say is HPV should be done. So if there's some disparity between the cytology and the colposcopy, or the lesion is extending beyond the transformation zone, or there is a suspicion that is extended into the endocervical canal, or there is some suspicion that there is some adenocarcinoma or invasive cancer that is included, then one has to go with this cone excision, cold cone therapy, so that you get the exact tissue which you can send for the histopathology, and the final diagnosis can be made and the treatment decided whether she needs chemotherapy or radiotherapy along with the management that you have done.
Only the disadvantage is cervical incompetence.
Yeah,
or-
so the disadvantages are that, there could be, if she is interested in pursuing her fertility, then she could have a bad obstetric history with mid-trimester abortions or preterm deliveries, or there could be some infection with cervicitis. So this has to be kept in mind.
Yeah, there are non-surgical treatments also like indole, this 3-carbinol orally It shows that 50% regression in treatment group as compared to placebo. Then this encapsulated plasma DNA, it is still under trial, but it is giving encouraging results. And therapeutic vaccine, subcutaneous injection or interferon intralesion injection or topical antiviral pseudofluvid we are using in some centers, but the trials are going on.
So, Dr. Archana Mishra, is it possible to eliminate cervical cancer? What do you think? Dr. Archana?
Yes, it is definitely possible to eliminate cervix. That is why proper vaccination of the young girls before the age of 15 years. And we should try that at least 90% of the girls are vaccinated before the age of 15 years. And the parents should be well counseled that most of the girls and boys, they get HPV infection, but that might land up in CA cervix in some or other cancers also in some people. So it is very, very important. They must be counseled very well, all the parents, that the girls must take vaccine at the age of 12 and must be completed before 15 years of age.
Yeah.
The
And-
second thing is screening. As our president, Dr. Shanta Kumari said that no patient visiting our OPD should leave without a PS examination. That is very important. And in many cases, you just find a lesion or a suspicious cervix and you can go ahead with the screening, because most of the patients, they don't come for screening in our country. So whosoever is coming must be screened for CA cervix.
Absolutely.
And the third thing is that if you get a lesion, it must be properly treated.
Yeah, and
So that
definitely
is the way.
elimination is feasible, right? But let us remember that status quo is not at all an option for us, because if you don't act now, the number of cases are going to increase dramatically, and you're going to, because of the if you don't have the change in behavior now, it will going to rise and rise. So there are a lot of benefits of a screening and treatment and prevention. You're going to avert almost 1 lakh cervical cancer cases if you screen and treat. Then of course elimination and prevention of deaths also. So now this is the case 1 we are going to talk
We have
about.
10 cases, but we will take them fast. Yeah, they are interesting.
So this is a 33 years P3L1 discharge per vaginum and 1 year menstrual cycle. Since 1 year she is having discharge per vaginum. Her menstrual cycles are regular. Per speculum examination, cervix is unhealthy. Bimanual examination reveals a normal size uterus. Bilateral fornices were free and non-tender. After application of acetic acid, a dull acetovite area was seen on the posterior lip of cervix. So Dr. Vaishali, what is to be done next in this case? Yeah.
So in this case, as you can see, the picture is not very good. So I would like to do immediately a colposcopy for her. Colposcopy is the gold standard diagnostic standard. And looking at this, probably this, if it turns out to be CIN1, it doesn't look like CIN23, but of course the colposcopy will help us make decision, especially the Sweets score, which sees, the margins and the vascularity and so on. And if it's just CIN1, then I would like to observe. I wouldn't like to go ahead and do excision, but careful observation, evaluation is required. Even if it's CIN1, there's almost 1% chance that it could become invasive, but most of the time there's a regression. But careful evaluation observation is important. And if we find that this patient has come from some rural area from far away and she's not likely to follow, then it's important to counsel the patient, that though it is CIN1, she needs a continuous follow-up. And if the patient is unwilling to follow-up, then maybe I may go ahead and do further biopsy and further treatment. But for CIN1, I would wait and watch and evaluate.
Yeah, now where the situations which require more vigilance is non-compliant for follow-up persists for more than 2 years, worsens or history of ASCUS that we are going to discuss, or higher and immunocompromised. So Dr. Charulata Bapaya, how will you manage such patients after treatment?
Yeah, so the point is that now this patient of yours, you've told her that she has a precancerous lesion and she's bound to be worried. You know, whenever anybody hears the word cancer, it's going to really scare them. Of course, the first thing that we do is reassure them, tell them that CIN1, the progression is extremely slow and there's a very, very small chance of going into malignancy, but she cannot be complacent. You have to let her know that she has to be under close follow-up. And how soon will you be doing this follow-up? You know, a year down the line, you're going to repeat a visual inspection of the cervix, maybe with acetic acid. You will repeat a cytology. And if all is well in that particular examination, then she is going to be posted just for a routine follow-up and a routine screening like any other young patient. You know, she's a 33-year-old. So like any other patient, we're going to follow her up later on. But if we feel that the lesion is persisting or it is progressing to CIN2 or CIN3, then now is the time that you might have to, repeat a colposcopy, take another biopsy. You already taken a biopsy, you've seen a lesion out there, you've taken a biopsy, and then you have to treat her according to whatever the lesion is.
So the Foxy has come up with GCPR, everybody knows it about it. So whatever, if there is aggression in the lesion, we should follow the Foxy CIN management GCPR. They are excellent, and just blindly follow them and you are on the track. So the treatment for low-grade ACIN, what Dr. Charulata correctly told us, CIN1, no treatment, cytological follow-up for 2 years and cryotherapy. So let us take case 2.
Yeah, case 2 is a 31-year-old. She's a paraben, complaints of persistent vaginal discharge, postcoital bleeding 6 months. Then menstrual cycles are regular. Cervix shows an irregular area on the cervix that bleeds on touch. Dr. Kusum Lata Meena, how do you evaluate this patient now?
Yeah, good afternoon, everyone. This is very good question Madam asked me. As every gynecologist now proceeding towards the fertility preservation or infertility clinics are there, every high-risk pregnancy is upgraded to infertility clinics. So this is very good question is there. Such patient, we need fertility preservation or conservation, or we have to go for conservative therapy, I mean it is. So such patient to be screened in the form of, we have to go for VIE. That is already the photo. You can see on the screen, the photos are there. That is come under the Sweden score. That is the cervix is divided into 4 quadrant.
Yeah,
That
Dr. Bharti Abhyankar will be talking about Sweden score. Okay.
Yeah. So such patient is to be screened by VIA, colposcopy, or Lugol-Sidon testing. The 3 pictures are there. Here you can see in the Sweden score, we have to see 5 characters.
So
That is
Dr. Bharti, okay. Dr.
surface-
Bharti, what is the next step? We have to go fast little bit. That's why. What is the next step, Dr. Bharti?
Yeah, you have done a
You are very
colposcopy
famous
and-
for colposcope. You made colposcope famous.
Thank you.
And
Thank you
are
so
doing
much.
excellent work. Kudos to you.
Thank you so much, madam, for the kind words. And once you have done a colposcopy, now we have got a very good scoring system that is called as a SWET scoring. And it has made our diagnosis very easy. One point I would like to stress is CIN 1, 2, 3 is a histological diagnosis. And you should not say after colposcopy that this is CIN1 and this is CIN2, but you should say that this is a low-grade squamous intraepithelial lesion, or it is a high-grade squamous intraepithelial lesion called as L-cell or H-cell. So depending upon the SWIT scoring, the 5 points that are considered are acetohyte uptake, then margin or surface of the lesion, presence of vessels on the lesion, then how much area is occupied by the lesion, and lastly, the staining with iodine. All the points are considered, the scoring is given as 0, 1, and 2. And at the end, you have to calculate the score. If the score comes in between 0 to 4, you can be sure that it is a low-grade squamous intraepithelial lesion, that is L-cell. If the score comes to be 5, 6, it may be either L-cell, either HPV, or a high-grade lesion. Or if the lesion or the scoring comes above 6, then definitely it is a high-grade lesion and you have to proceed for the biopsy. One more important point is your biopsy should always be colposcopy guided biopsy. There is no role of punch biopsy nowadays in diagnosing pre-malignant lesion.
Okay, so the interpretation is like your low-grade normal CIN1, high-grade invasive cancer if it is 5 to 6. So 4 to 6 is the cutoff to diagnose. And the colposcopy SWID score 8 and HPCIN2 is more significant, and you have to treat the patient accordingly. So anybody can take it. Does she require any treatment?
So we are talking of CIN2 now. Is the treatment required or not? Anybody can take this question. How to manage?
Yeah, for the treatment of such patient, we must know about the natural history. That cancer cervix start right from the inflammatory to it goes to invasive stage. So first is inflammatory, then it becomes CIN1, CIN2, CIN3, CIS, and the invasive cancer. Till CIS, it is reversible. That is 58% it can regress to say inflammatory or CIN1, or 22% it can progress to invasive cancer. Only 5% there is invasive. So CIS is 22%. So we have to be very vigilant. We have to go for the marker. That is 16, 18 strain for HPV or HIV testing. That is very dangerous. And we have such patient to be taken as an upgraded stage. If it's CIN1, we have to be assume it is a CIS3 or CIS stage. So it to be upgraded, it is treated according to the upgraded stage. But we have to have a fertility preservation.
CIN2, can we talk about
if it is CIN2, then we have to follow the CIN2 GCPR guidelines. What in that, if it is strain 16 or 67 is positive, then such patient to be close follow-up as he says postcoital bleeding is there. So we have to screen 6 monthly. If it is turned up negative, then yearly. If it again it turn up after 1 year it is negative, then we have to follow it 3 yearly or 5 yearly. But if it's HIV positive, then we have to take it into high risk with the close follow-up in the form of 6 months. Or for that, we have to again go for the combined testing, screening, VIA, HPV DNA testing, LBS cytology. Then we have to go for further testing. And if it is progress, then to be treated as a trachelectomy because fertility preservation is required.
Definitely.
If there's still it's progress, we have to go for the radical treatment.
So this is the
Dr.
DCPR guidelines.
Surekha, your question was, would you like to treat it? And I would just simply like to say, yes, I would like to treat this. I would like to do a colposcopy, leave, diagnose as well as treat immediately.
Yeah. So CIN2, we really have to be alert. Here, the treatment is required. As you have rightly said, excisional procedure may be needed or ablative procedure. You have to follow this GCPR guidelines very nicely given there. So we move on to the next. After doing this treatment, what next, Dr. Anuradha?
So after doing test, follow-up is very important. We do a co-test with HPV and cytology at 6 months, 1 year and 2 years. And if it's negative, we put the patient for the routine screening. Now, if colposcopy report comes conclusive, we have to do the excision of the transformation zone. And later we will follow up at around 1 to 2 years with the HPV and cytology. And if it is negative, we will do at 3 years. And if that comes negative, we push them to the routine screening. Now, if our colposcopy report is inconclusive, or we have an endocervical curettings which are positive, or we have slight doubt that, there is no correlation between the cytology report and the colposcopy report, we should put the patient for a diagnostic excision. And there what we check for the margins. If margins are negative, we follow the same routine of follow-up at 1 to 2 years, and then, put them for routine screening later on. But if margin is positive, then we have to follow them up more carefully. We can do a repeat cone biopsy if it's technically possible. Or otherwise, if patient is non-compliant, you can even go for a hysterectomy where you think that she may be lost to follow.
Mainly to follow the FOXY-CIN management GCPR. They are very, very.
Yeah, Dr. Varsha, I would like to add something here. If it is, the marker is negative, still we can go for the vaccination such patient.
The age.
At the age is any age group. It is still 60, before 62, you can vaccinate the female.
Yeah.
And
This is a new
in adult-
take home you are giving because it was told that 45 years tak dene ka hai, uske baad nahi dene ka hai. So you said that you are.
now the GCPR is there, upgraded,
That's
we
what
can
I
give
wanted
it
you
before
to tell.
62, not after 62.
Okay.
So vaccination start at the age of 9 years, and it continue till 62 years, but we require a fertility is an issue in this case. In this case, we have to be consult the patient ki after vaccination, you have to be have abstinence.
You have the
or-
excellent slide you have given to me. We will post it in the groups afterwards. Do you think the treatment is over?
Poster
Dr.
over there, you can see later on.
Yeah. Do you think the treatment is over, Dr. Achla Batra? What is the situation for increased risk of recurrence and persistence?
See, once you have treated CIN2 does not mean your job is over, because there is 2 to 5 times higher risk of these women getting recurrent CIN. So they have to be on follow for next 20 to 25 years, because especially there are people who are at high risk, like if you have margins positive, then age more than 40 and others say 50, if you have very large lesion, if you have HIV, or if you have glandular involvement. Especially with glandular involvement, the risk of recurrence is 16% compared to squamous epithelial lesion. So these patients have to be carefully followed up. And if you have two factors, suppose somebody is more than 50 and she has margins positive, then I would not keep her for follow-up. I'd like to go for hysterectomy for this woman because she has another risk factor of age being more than 50. Similarly, glandular involvement also, if you have to be very, very careful. And if she is more than 40 or 50, it is better to do an hysterectomy than to keep her on follow-up, because glandular involvement are known to have skip lesions, You might miss out on the lesion. That's why these patients have to be very carefully followed. I mean, from the maybe till her life, or at least 25 years, she needs to be followed up.
Very wise advice you have given, Dr. Achla Batra. You really are what's a pickled gynecologist, I will say, because you are really counseling it very well. Thank you for your answer. So friends, we have prepared many cases, but I cannot take for want of time. What I will do is last, but one we will take it, because already our panelists have answered one each, and they have covered many questions. But only one we will take it as what is adequate smear. Dr. Nishi Gupta. This was a case with
For adequate smear, there should be at least 8,000 to 12,000 of well-educated squamous cells, and there should be transformation zone cells visible, because it is the most susceptible area to be affected by squamous cell carcinoma. And wish for well visualization of columnar glandular cells of endocervix plus squamous cell of ectocervix, both should be there. And it should not be covered more than 75% by blood and exudates. For that, precautions should be taken that patient should be warned to avoid contact for 2 days before.
Very good. Thank you.
Avoid using any medication, vaginal douching, etc.
So what is inadequate smear, Dr. Kalpana Kumar? Adequate smear.
Dr. Nishi has already told what is the adequate. So rest of these things is inadequate.
Absolutely.
That means.
So what is your action there?
It should be properly labeled also, and it should be when it is not there, it's endocervical cell should always be there. And
so the treatment is treat inflammation, repeat the smear, still inadequate, colposcopy kar do. So then that is the algorithm. And what is you understand by this report? HPV positive hai patient, 31-year-old lady. Dr. Achla Batra, quick answer. Take a mic and talk briskly and short.
So if somebody comes HPV positive, first thing is we have to reassure that all HPV positive is not precancerous. Then this patient has to be, she has 3 options depending upon the setting you are in. If you cannot do much, at least you can do a VIA or a cytology, or if you have very good facilities, you can go in for, genotyping, because HPV 16, 18, they are likely to progress, likely to have, precancerous lesions.
Yes.
So,
So we have to
depending on
repeat the HPV testing after 1 year. If it is negative, reassure. Case number 9.
So this is a 34-year-old para-3 VIA positive, and this is how the cervix looks like. What is your corpuscular diagnosis? And Dr. Bharti,
And what
can
is
you
the plan?
explain about the plan of management of this patient?
Can you show me the picture once, please?
Yeah.
Okay, thank you. So we have done her VIA and the VIA is positive. So definitely after seeing the lesion, I'm sure that she needs a colposcopy. If the patient is from a rural area, you are sure that she's not going to come for a follow-up or any further investigations, then definitely I would like to screen and treat modality for her.
Yes.
The cryotherapy will be the best option for her. But if you are sure that your patient is compliant, she's going to come for follow-up, then definitely I will triage her with HPV and liquid-based cytology, which will be the best for her. And depending upon the positivity of that, if it is positive, then we have to go for colposcopy, and you can do biopsy also and treat her accordingly.
So many a times HPV testing is not available even in premier institutions. So that's the problem actually. So that's why the
VIA is
colposcopy and the VIA, after VIA to the colposcopic biopsy, and accordingly to the scoring, you can take a biopsy, and according to the result, you can manage.
So not every patient should undergo hysterectomy, and not on every patient should be afraid of it. You can assure, because CA cervix is a very slow growing cancer, and precancerous condition, we can catch the patients. So now we will take the last case. Now 31-year-old lady comes with pap smear report of ascus. So Charulata, can you highlight what is ascus? Madam Bapaye.
So this is a pap smear report which we will get. You sent a pap smear of your patient and it comes as ascus. So firstly is the full form, which is atypical squamous cells of undeterminate significance. That means even the pathologist has not been able to tell you 100% that what exactly is it. It is neither a negative report nor does it signify anything positive. Okay. But that does not mean that it is of no significance. It is as of now of undeterminate significance. So now what do we do next? So what we do next is we do the HPV testing. Now, if the HPV testing comes positive, okay, your tentacles are up, that, she is a little at the high risk category and you need to follow her up significantly. If she's HPV negative, you still would like to repeat her cytology, say, 6 months down the line, and, see whether there is any progression of this particular thing. So it is a very indeterminate group of patients where the cells neither show any typical pre-malignant cells, but neither are they very normal and regular. So at the end, if after 6 months the cytology comes negative once again, you're fine. You tell her nothing to worry. But if you see some progression, it looks like CIN1, then yes, you will follow her up as a CIN1 patient.
So Bharti More, what is your opinion for borderline nuclear changes in the endocervical cells? Last question.
Yeah, borderline nuclear changes is where, there is a chance of at least 14% that it could go to, it could be pre-malignancy, invasive, or it could be malignancy in almost 40% of the cases.
Yes,
so
absolutely.
these patients have to be carefully monitored. And depending on the age, if she's around about 50 years, she's finished, like she's menopausal, postmenopausal, in that case, we would advise a hysterectomy. But if she's a younger patient, then we need to have vigilant follow-up for this patient, where there are more chances that she might go into invasive, pre-invasive, or in malignancy.
Thank you, madam, for excellent. So vaccination with screening with HPV is probably the most realistic intervention for cervical cancer prevention in the long term. So in our hand, what is in our hand? We rise by lifting others. And so thank you all the esteemed panelists for your excellent
Thank you very much.
deliberations.
And I think we had a great panel with really academically strong people here who are you have given us great take-home messages also. So thank you to the panelists also for great information.
Thank
you
you. Thank
so
you,
much.
organizers, for giving me the opportunity to talk in front of this August gathering as a moderator, along with my academia, Dr. Surekha Taide. Thank you.
On behalf of all the panelists, we want to thank our esteemed dear Dr. Varsha Baste, Madam, and Dr. Surekha Taide for such fantastic questions and for conducting the panel so
Thank you.
nicely.
Can
Thank
we
you
have
so
the-
much for the opportunity.
Thank you.
And thank you for Turkey.
Yeah. So we will have a photograph.
Hello, is there Mr. Ravi Kaul is here? Mr. Ravi Kaul? Kindly display my poster now, please. Display my poster. Yeah. Hello, all of you can see on the screen. I request Shanta ma'am. Excuse me, Shanta ma'am, thanks for giving this opportunity. There is a poster that can be included in your WOW program. This is for school health WOW program. This is for the vaccination of the students or school going children, male boys as well as the Doctor.
Hello. Can you hear us? Now all of you come for the group photograph.
All right, request everyone to please come over here for the group photograph, please. We request all the doctors, all ladies and gentlemen, please come over here for the group photograph. Request all the doctors, all the ladies and gentlemen, please proceed further for the group photograph.